So I'm Claire Baker. I'm Senior Director of Communications at Beyond Celiac. Soon I'll introduce Alice Bast. She's the Beyond Celiac Chief Executive Officer, and she'll give us a welcome. She'll introduce our Chief Science and Strategy Officer, Salvatore Alesci, for opening remark to set the stage. Then we're going to have 3 hour-long sessions. When you registered, you had the chance to ask questions then, and we've asked our presenters to include answers to those questions as it makes sense into the presentation that they're going to make. I think it's time to get started. I'm going to invite Alice to turn on her camera. There we go. Hi, Alice.
Hi, Claire. Thank you.
You bet. I'm gonna hide myself.
Great. Thanks, Claire. So I want to welcome you all to Beyond Celiac's 2021 Mini-Conference, Hidden in Plain Sight, an interdisciplinary slate of panelists comprised of physicians, researchers, and patients will address the very real challenges people with celiac disease experience in getting a timely and accurate diagnosis. For a little history, some of you might have heard this, but many haven't. I myself went undiagnosed for 8 years. I had a full-term stillborn child. I had multiple miscarriages. My youngest daughter was born at 2 pounds. I had many other symptoms from my head to my toes. My hair was all falling out. My teeth were breaking and brittle. I had peripheral neuropathy, that's tingling in your fingers and toes. And I lived my life in the bathroom. I was 105 pounds and I'm 5'9". And then the doctors told me it was all in my head. I could have had postpartum depression. My mom died young of pancreatic cancer, and I thought I was dying of cancer as well. Finally, after seeking the help of 22 doctors, a family friend who is a veterinarian, yes, she sees the whole animal, she suggested my problem could be connected to diet. She was the first person to mention celiac disease. I went to my physician, he was Dr. 23, he was a gastroenterologist, and asked to be tested. He said I was too tall to have celiac disease. I insisted, here's my arm. He finally agreed, I got tested, and I had my answer, celiac disease. I founded this organization, Beyond Celiac, so that others could avoid the same pain and suffering. And though our mission has pivoted to that of accelerating research for treatments and a cure by 2030, we know that even with treatment options, accurate and timely diagnosis is an absolute must for our community to live better longer. Which is why we have assembled this mini conference today. 3 sessions, as Claire had mentioned, that will address misdiagnosis from different angles. We're happy that hundreds of people from around the world have registered. Welcome everybody from all over the globe. And we're thrilled to have you here as part of our community. Now, I'm pleased to introduce our Chief Science and Strategy Officer, Dr. Salvo Alessi, who will set the stage for us before we jump into that first session. Welcome, Salvo.
Thank you, Alice, and welcome everyone. It's a pleasure to be here. As a physician scientist, I have spent the last 2 decades of my career devoting it to research and development, both in the government and pharmaceutical settings. And I've decided to join Beyond Celiac, you, Alice, and the team, because I wanted to be part of a team that can truly contribute to the development of meaningful treatment and eventually a cure for celiac disease, a disease that has affected personally myself and my family. My daughter Asia, who is now 19, was diagnosed with stage 4 when she was 8. And wow, what a journey. Similar to Alice, her presentation was atypical. Her presentation was mostly characterized by neurological symptoms, which of course delayed the diagnosis, despite being in an area with excellent healthcare. This story is way too common, and actually it's the focus of the first session, where you're going to hear specifically about the patient perspective and the science being done to address the neurological component and non-GI component of celiac disease. The diagnostic rate of celiac disease in 2003 was only 3%. Thanks to the hard work of Beyond Celiac and other organizations, the number now has increased and is somewhere between 17 and 50%. Still much more work needs to be done. And there are millions of people across the globe that have celiac disease, but they simply just don't know it. Celiac disease is a serious, progressive autoimmune disease, and early and accurate diagnosis is essential to make sure that you give the people affected the best chances to live healthy and enjoyable life. It's not acceptable that so many people today still remain undiagnosed and face the potential consequences of untreated celiac disease. I truly hope that this conference, and especially the stories that you will hear from the people that have been directly affected, will shed light on the many difficulties of their journey to just get to an accurate diagnosis, and hopefully will provide some guidance for all working in this sector to come up with solutions to this problem. We are very fortunate today, as Alice pointed out, to have assembled a remarkable group of panelists, bringing together the patient stories and the latest research. I'd like now to introduce Kate Avery, the Beyond Celiac Director of Research and Patient Engagement, who will kick off the first session. Kate?
Great, thanks, Salvo. I think right before we're going to start with this session, Claire is going to ask our attendees a question.
Yeah, so we thought it'd be interesting to get a sense of what your journey to diagnosis was like in terms of what your symptoms were. So I'm gonna share a poll. We'll give you a minute or two to consider how long did you or your child have signs or symptoms of celiac disease or gluten sensitivity prior to diagnosis. And if you're if you yourself don't have celiac disease, if you're a healthcare provider or a researcher, this will be good information for you to know, just as we see who in the room has what. Okay, we'll give you just another minute. I'm sorry, you guys caught me looking at my other computer. All right, we're going to count it down. 3, 2, 1, end poll. Let's see, share results. There we go. So it looks like most people on our call right now, we're just about 100 people in the call right now. 1 to 5 years, 43% of you took 1 to 5 years to get diagnosed. And so I don't know if it's surprising or not, and unfortunate 14% took more than 20 years. And I'm in that bucket. I had anemia for 25 years without anybody really taking note of that as anything other than, that's kind of surprising. So I'm going to stop sharing the poll. Want to note that our staff that put this together, we're in addition, Alice, in addition to having celiac disease, I do as well. Salvo's personally affected. He's got family with celiac disease. Bailey Arman, our communications associate, who's helping run the train behind the scenes, also does. So for many of us, celiac disease is both a personal and professional calling. I think since we have all our panelists for the first session here, let's get started a couple of minutes early there, and I'm going to bow out and turn it over to Kate Avery, who will introduce herself and our panelists.
Great,
away, Kate.
Thanks, Claire. So I'm Kate Avery. I'm the Director of Research and Patient Engagement at Beyond Celiac, and I'm joined today by 3 panelists, Gabrielle Zimmerman, who has celiac disease herself and is going to share her diagnosis story with us, as well as Iain Croall and Nigel Hoggard, who are researchers from the University of Sheffield, which is in the United Kingdom, and they're here to share their research on non-GI symptoms of celiac disease. So our topic today is It's All in Your Head, Misdiagnosis Due to Neurological Symptoms of Celiac Disease. And I'm going to give my three panelists a minute to just introduce themselves briefly. Gabrielle, would you like to start?
Sure. Hi, I'm Gabrielle Zimmerman. First of all, I just want to thank the Beyond Celiac team for allowing me to speak at this conference today. I just know that the 10-year-old girl who was diagnosed with celiac disease 14 years ago would be so proud to see that this event is taking place today and to know that I would get to share my story.
Great, thanks, Gabrielle. Iain, would you like to go next?
Hi everyone, my name's Iain Croall. As Kate has said, I'm one of two researchers on the call along with Nigel, who are both based at the University of Sheffield in the UK. My background academically, I'm an academic doctor rather than a clinical one, I should say, is very much neuroscience and brain imaging of conditions that affect the brain. So I've previously worked with forms of dementia and head injury and things like this. But I've been at the University of Sheffield now for, I think, coming up 5 or 6 years, where I've been kind of firmly embedded in this research about how the full spectrum of gluten sensitivity can affect the brain, and using MRI scanning to investigate that as well. So I'd also like to thank very much Beyond Celiac for having us here today. It's a real pleasure to be speaking, and I hope you will enjoy the session.
Hi, I'm Nigel. I'm a Professor of Neurology here in Sheffield. I'm part of a larger group that's been studying celiac disease here in Sheffield for the last few decades. I guess from the neurological point of view, our work dates back to some seminal work by Marios Hadjivasiliou, who's here in Sheffield back in the 1990s, which showed a large proportion of patients in the neurology clinics with unexplained symptoms showing up positive for antibodies to gluten, and that's where the story started back in the 90s for us.
Great, thanks so much to all three of you. So today we're going to start with Gabrielle sharing her story, and then I'm going to talk briefly about some research Beyond Celiac has done and some data that we've collected, and then we'll end with Iain and Nigel sharing their research with us. So Gabrielle, you can go ahead. Thank you.
All right. So with my story, back in the day, I was a big performer and I had the wonderful opportunity to sing at the US Open back in 2007 at the end of the year. And then starting in January of 2008, I started to forget lyrics to songs, which was very unusual for me. You know, these were songs that I would sing all the time and I would go to New York City to audition with. And yeah, it was just very unusual. And then, you know, I would also I started to have problems with like simple math problems and even telling time. And like there were times where I would just stare. I would just be staring and my mom would literally have to wave her hand and say my name multiple times, Gabrielle, Gabrielle, to snap me out of the trance. And then one day I woke up and I couldn't feel my legs and I couldn't feel my fingers. And it was, you know, very traumatic and scary. It felt like my legs and my fingers had just fallen asleep and I just couldn't feel my body. And then, you know, I ended up going to the hospital that day. My mom took me to the hospital and I left there basically without any answers as to why I couldn't feel my legs. And I was tested for MS and different cancers. It was, you know, it was a very scary time of my life. And then I started to get migraine headaches. And these were excruciatingly painful to the point where my mom would literally have to put her hand on my head to apply pressure in order to alleviate some of the pain. And, you know, it was so bad. And it would leave me debilitated, you know, laying down on the couch and not being able to really do anything and live my life. And, you know, sadly, you know, every doctor that I went to, you know, kept telling me it was just anxiety and it was basically just all in my head. And, no one really understood. No one really understood. And, I had just sang, in front of thousands of people, and I had no anxiety. If I was able to do that, then, how come they were, saying that it was anxiety when it really wasn't the case. And the one person who believed that was my mom, for sure. She said, no, my daughter does not have anxiety. There's something seriously wrong, and I want to find out. And then, fortunately, one day she came across a story that she found online about a boy who had similar symptoms as me and was diagnosed with celiac disease. And so she, in turn, she told my pediatrician at the time and asked him if he would test me for celiac disease. And at first, he actually refused to test me, claiming that I had no GI symptoms, and that when he was in medical school, his professor told him that he would probably never see celiac disease in his entire lifetime. And so, after a few months of that, of my mom trying to, push for me to at least get tested, better to rule it out and, to be safe than sorry, he finally gave in, and I was tested, and my results were off the charts, and I was tested positive for celiac disease. I got an endoscopy, but even before I even got the results for the endoscopy, the doctor came out and said to us, she definitely has celiac disease. So yeah, and it wasn't until the very end, about 2 months after I started having symptoms, initially in January, that I had GI symptoms, and at the end, I just basically stopped eating, and I was tiny to begin with. So yeah, and that is kind of the journey of reaching a celiac diagnosis for me.
Thanks so much, Gabrielle. Just before we move on, can you talk a little bit more about, did your symptoms resolve quickly once you went on a gluten-free diet? What did that look like for you?
Yeah, so I was looking actually at some of my medical records from that time, and it seemed that even after a year of going on the gluten-free diet, I continued to have the same migraines that I had. I still had that, brain fog or stare. I would do that, and I still continued to, like, with simple math problems and telling time, there were still some things. So it wasn't until a little bit after a year where I really started to get back to feeling like myself, and getting back to my life and school and everything. Yeah.
Wow. Well, thank you so much. I'm so glad that you're here to share your story with us. I'm so sorry that you got so sick and it took you so long to get diagnosed. I'm glad that your mom was able to be such a strong advocate for you and to, keep pushing for some kind of an answer, and then to not take no for an answer when she thought she had figured it out. I'm sure we'll have a lot more questions for you in the Q&A as well, because I think your story is a perfect illustration of why we need these non-GI symptoms of celiac disease to be more recognized. So I'm just going to talk briefly about some of the symptoms that are reported in our patient registry, as well as a study that we published in 2020 that was specifically about brain fog and celiac disease. So Go Beyond Celiac is our patient registry, and in Go Beyond Celiac, we're collecting information directly from the celiac disease community through a series of surveys. So we're collecting information that's important to researchers who want to study celiac disease, but as a patient advocacy organization, our surveys were informed not just by physicians and researchers. We also wanted to make sure that they reflected the actual experiences of the community, which we know are sometimes different than what researchers and doctors expect. So for example, a number of years ago, it was believed that people with celiac disease couldn't experience symptoms of getting gluten right away. They thought, it had to at least be a few hours before you would start to experience symptoms. So we did a survey of the community and learned that many people can tell if they've been glutened within 30 minutes because they do start to experience those symptoms. And that survey helped to inform researchers about how the immune response happens in celiac disease. So when we developed Go Beyond Celiac, our registry, we really wanted to make sure that we were asking those right questions about all kinds of symptoms, not just GI symptoms. So there's 2 surveys in there that ask about symptoms, the My Symptoms survey and the gluten exposure survey. And they're about symptoms that are experienced both before and after diagnosis. We know that sometimes after diagnosis and when someone is on the diet, they might have different symptoms to gluten exposure than they did before. So we do ask about GI symptoms, and we split symptoms up into different categories. And in the neurological category, we ask about headaches, brain fog, neuropathy, which is tingling or numbness in your hands or feet, joint pain, and ataxia, which is problems with muscle coordination. So in that group of symptoms, brain fog is the most commonly reported, with about 85% of participants saying that they have it. Now, I will talk more about brain fog at the end because we've done some additional interdisciplinary research about it. So the next most common symptom in that group is headaches or migraines. Like Gabrielle talked about 70% of people have those, followed by joint pain at 64%. So about 2/3 of the people in Go Beyond Celiac are experiencing one of these neurological symptoms with gluten exposure. And about 40% of the people who experience any of these symptoms, migraines, brain fog, and joint pain, say that their symptom is severe or very severe. Neuropathy is a little bit less common, but it's still about half of people who are reporting that. And it's about 1/4 of people who are reporting having ataxia with gluten exposure. So we also ask about some additional neurological symptoms: anxiety, depression, fatigue, and irritability. And fatigue is very widely reported, with about 90% of participants reporting fatigue. I think it's not only one of the most common, but it's also one of the ones that people rated as the most severe. So 62% of people who said that they have fatigue said it's severe or very severe. About 2/3 of people say that they experience anxiety. And then irritability or fussiness, which is often a symptom seen in children, especially young children, was reported by 70% of participants. So, I mean, what this tells us really is that extraintestinal symptoms are very common in people with celiac disease. And furthermore, these are symptoms that are impacting people's daily lives. Having severe fatigue can make school and work very difficult. It makes just your daily life difficult. Similarly, brain fog, headaches, joint pain, all of those can interfere with your daily life, not to mention your work and your school performance. So not only are these symptoms common, but they could be having a really big negative impact on people with celiac disease and non-celiac gluten sensitivity. So it's important that more research is done on these symptoms, and it's also important that doctors recognize these as symptoms of celiac disease. That could go a long way in getting people like Gabrielle a diagnosis more quickly, and understanding more about these non-GI symptoms can also help in follow-up doctor's appointments, so physicians can tell if the diet is working for their patients. So I definitely want to invite everyone who's watching at home to join Go Beyond Celiac to help us collect even more data around these important topics. And you can learn more at go.beyondceliac.org, which I'm sure my coworkers will also be putting into the chat. So to talk a little bit more specifically about brain fog and the paper that we published. So in 2020, we published an interdisciplinary research study that looked at the experiences of brain fog in people with celiac disease and NCGS. So for many years, I mean, I'd say certainly since Alice first founded the organization, we had heard from people that they were experiencing brain fog, but there wasn't a lot in the scientific literature about it. So we partnered with researchers at Beth Israel Deaconess and Northeastern University, which are both in Boston, to conduct a survey study to learn more about the experience of brain fog, including what it's like to experience it, and then how long the symptoms last, how fast they come on, things like that. So our survey went out to our community through email and social media. About 1,400 people filled out the survey. And we found that brain fog was experienced by about 90% of survey participants. And participants had both, or could have either celiac disease or non-celiac gluten sensitivity. We gave people, they could choose between 5 words to describe their brain fog. And these were words that we had heard the communities frequently using to describe brain fog. They were grogginess, mental confusion, detachment, difficulty concentrating, and forgetfulness. And of those 5 descriptors, the most frequently chosen were difficulty concentrating, grogginess, and forgetfulness. So we also wanted to understand more about the timing of brain fog. So most people said that it starts within about 30 minutes to an hour after they ingest gluten. It reaches a peak within 24 hours, and that it lasts between 1 and 2 days. So I think what's notable here again is that this is a symptom that's affecting people's lives, and again, you know, is affecting your work life or your school life. And it's not just the same day that you get gluten that it could be a problem. You know, it's up to 2 days later that you might still be struggling with brain fog, still be struggling to get things done. So our paper really pushes for more research into brain fog as a symptom. And we hope that doctors can use some of these words, mental confusion, grogginess, forgetfulness, in visits to, you know, ask their patients about them. Are they experiencing these symptoms? And then also to recognize that when patients use those words, they're describing brain fog. They just don't always have the word, you know, or the term brain fog to use. So finally, we're also hopeful that brain fog would eventually be a symptom measured in clinical trials to make sure that any treatments that are being developed for celiac disease will not only help gastrointestinal symptoms, but will also help neurological symptoms like brain fog. So if you're interested in learning more about the brain fog study, we do have a write-up on it in our research news feed, which I'm sure someone will link. And if you'd like to see our whole paper, you can send me an email and I can send you a copy of it. So some of the good news about the non-GI symptoms getting studied by scientists is that we have 2 people here who've spent a number of years researching the neurological symptoms of celiac disease and NCGS. So they're now going to share some of the details about their research into neurological symptoms and specifically about changes to the brain that are seen in both groups of people. So we're really glad to have you guys both here with us today.
Thanks, Kate. I think the plan, as we discussed it, I'm going to now give a kind of a short presentation, just as a general overview of the sort of research that we do. And then following that, we're going to have more of like an open chat sort of panelist discussion. We'll bring in Nigel, will jump in a lot at that point, I suspect, as the person out of the 2 of us who's qualified to give actual medical advice, I'm sure will be invaluable as well. So I'm going to start sharing my screen now. And I will do let me know if the PowerPoint presentation seems to be working, if everyone can see that. Yeah, okay.
I can see it, yep.
So, as I explained before, we are very interested at the University of Sheffield in looking, you know, very specifically at the neurological outcomes that can be involved in people who've got celiac disease or NCGS, you know, kind of the full set of what you might call gluten sensitivity. And I think one of the things that we're fairly unique in is that we do an awful lot with brain imaging in the study of this as well. So just a couple of photos here, the top left picture, it's kind of a lab that we work out of here doing all the image analysis, and then there's a couple of the scanners which we use on the right hand side, both for kind of clinical care of these patients and also for research studies as well. So, as I think has already been alluded to quite a lot, and it sounds like everyone here is already quite primed to think down these lines, but it's always good to reiterate that having an issue of gluten is not just having celiac disease. You know, there's this whole kind of spectrum behind that. So this is where this iceberg metaphor, I think, comes in really handy. You know, we have at the top the bit that you can see, classical celiac disease, what, you know, hopefully your doctor is familiar with and hopefully might be, you know, willing to investigate. We've got relatively okay at this, but clearly, as we've already said, more work needs to be done. But this is the part that I think we understand the best. But then beneath that, of course, you know, we slowly start to uncover what is seemingly a much larger population of people who have got a kind of like a mixed presentation that doesn't fit that textbook definition. So this can involve people who have diagnosable celiac disease, who also have got neurological manifestations of it on top of that. But then, of course, we also start to get into the NCGS population as well, who don't necessarily have celiac disease as we would diagnose it, but who still have issues relating to gluten sensitivity, either with their gut or sometimes only with their brain. When starting to talk about what we can expect, I've always actually found it very useful to start out talking about this group of patients who seem to experience only neurological conditions related to gluten sensitivity. And at Sheffield, we have a specialist clinic where we get patients from all over the country who are referred for just this reason. So there's a couple of conditions that we've kind of got names for now that relate to this. So these are gluten ataxia and gluten encephalopathy. And again, just to reiterate, people who have these do not necessarily have celiac disease at all. And this is also kind of really the sharp end of the stick. These are conditions which at the extreme presentation are thankfully relatively rare, but they're also very under-recognized as well at the same time. So I think very important to study. So we can see quite clearly what's going on in these patients when we do brain imaging. So for gluten ataxia, what we tend to see is the part of the brain known as the cerebellum, which is what's circled in red here, undergoes a lot of atrophy. And, you know, we can see in these patients that it will shrink. And I think we can all kind of have an intuition that the thing I've highlighted is not as big as it should be. And then in terms of gluten encephalopathy, doesn't necessarily affect the cerebellum so much, but what we get instead of these things that you would term white matter changes. The white matter in the brain is kind of like the wires that run through the middle of the brain and connect all the thinking parts together. So, you know, clearly it's an important part of how we think, so it can communicate. And what we see on brain imaging, certain kinds of brain imaging, is that people's white matter can start to develop these very kind of bright blobs throughout it. And an amount of this is normal and expected as we get older, but what we have on screen at the moment is a very extreme case of this, where huge amounts of this patient's white matter have developed these kind of bright blobs, and is clearly very unusual. Depending on which route the patient is going down more, we expect different sort of constellations of symptoms. So the more the cerebellum gets involved, the more we see symptoms to do with things like movement, coordination, sensation, balance, these sorts of things. And the more the white matter gets involved, that is what seems to correlate more with, you know, these kind of very migraine-like headaches, cognitive problems, and, you know, foggy brain as well. So it's worth mentioning kind of straight away that when we get patients like this, the gluten-free diet is the treatment. You know, it's kind of straight onto a strict gluten-free diet. And from clinical experience, this certainly is, you know, fairly effective in these patients. There are many patients who on a strict gluten-free diet, it seems to stop things getting any worse dead, you know, like they're then stable from that point forwards. And, you know, other patients, it massively slows down the progression. But as I'm sure we'll get into in the Q&A, how we separate these out and just how effective it is still a little bit of an open question. But we certainly know that if somebody doesn't follow a gluten-free diet at this point, it's bad news. There's a minority of patients we see who, even though they have these fairly extreme presentations at baseline, choose not to go on a gluten-free diet. And this is one such case of someone in their 60s who, you know, we can kind of see it over the course of 2 years. The amount of these white matter blobs that kind of sprung up in the brain, you know, became quite a lot more pronounced over time, over a relatively short amount of time. So one of the things I'm trying to hopefully get across at this point is how useful imaging is. And I know I'm going to be a bit biased myself for this because it's very much what my wheelhouse is in investigating these things, but it really is a very effective and wonderful tool for this. All the things I've shown so far are what I would call structural imaging. And I think it's what everyone tends to think of as an MRI scan as being, you know, it's kind of like you're taking a photograph of the inside of your head, surely. It's black and white and it kind of looks like this. And this is obviously useful for seeing things which are clearly quite physical changes that can happen in the brain, and which are very useful in diagnosis. But an MRI scanner can do a lot of other things as well. One of the other things that we find very useful in the clinical care and research sort of realm of this is what you might call metabolic imaging. This is where you don't so much get a photograph of the brain, it's still done on the same scanner as all the rest of it, but it more looks at a part of the brain that you want to focus on, and we get this kind of squiggly graph that I've got an example of on the left here, and depending on where the lines kind of shoot up the most, we know that one line means this is how much of a certain chemical someone has, this next line is how much of a different chemical someone has. So we're looking at the brain's biochemistry doing this. And something which we find is very effective in people who've got gluten-related neurological issues is this one on the right, which is called N-acetyl aspartate. We shorten that to the acronym NAA. And we basically find that the more you have of that, the better. And people who have gluten-related issues, we tend to find that that gets quite depressed and, you know, the levels of that lower. So the graph we have on the right is the outcome of an experiment a few years ago, which we did, where we showed that these patients we had coming through, you know, we have the level of NAA at baseline, and we found that then over time, it actually corresponded, you know, really quite closely to how successfully they appeared to be following the gluten-free diet. So those patients who said, I'm going on a gluten-free diet, and we found that they became immunologically negative, you know, all their antibodies disappeared, actually had quite a pronounced recovery of NAA in the brain. We can see that line going up. The patients who are labeled on the graph as being a partial diet, they're the people who said, I'm going on a diet, but the immune response, they still had a bit of an immune response. That was more of just a stable flat line. And then these patients who sometimes say, I'm not bothering with the diet at all, we can see that the level worsens over time. And then finally, we have what I could call more kind of advanced types of scanning, which is what can be very, very useful. So as I've been saying, these examples we have of patients who have quite pronounced neurological issues, you know, clearly very important to treat, but, you know, we're aware as well, they're not necessarily representative of, you know, most people's gluten sensitivity. Quite how representative they are is still an open question. But a lot of the resistance that I think we find in the research community to all of this becoming much more accepted is because most doctors' impressions of their patients with celiac disease is, you know, they don't have full-blown dementia and, you know, they're not wheelchair bound, so surely nothing's happening at all. And, you know, that's obviously a very reductive way of looking at it. And what we often find we need are more kind of sensitive ways of proving that physical things are still happening in the brain. Because sometimes you'll have these patients come through who have typical celiac disease, which is what these images are an example of. They don't necessarily have these pronounced changes on the structural scans, but we can still see, as this experiment proved, that if we look at people with typical celiac disease and compare them to matched controls, this kind of MRI scan, which images the brain's white matter, as I said, it's the wires in the brain, and it really does look like that when you kind of put up this image on screen. It's a very, very sensitive way at detecting subtle changes in the white matter, and we showed in this experiment that sure enough, these patients with celiac disease, there were areas of the white matter tract highlighted by these red blobs on the right-hand side that were showing changes relative to controls. So this is still sort of physical changes in the brain, which we're detecting using this kind of imaging. So all of this, you know, leads us to this question, which I know is kind of central to all of this. What neurological symptoms can people with celiac disease have? Just to round off the presentation briefly, I'm going to very quickly detail an experiment we did characterizing this. Of course, as Kate has just very eloquently gone through, we know there's this whole, you know, brain fog is very, very common symptom. There's also questions of cognition and mood. This particular experiment focused on very kind of neurological signs and symptoms, which is a part of this. So in this experiment, we recruited 100 patients with celiac disease. Importantly, they were all from gastroenterology. None of them had any history of neurological problems, and the point of recruitment was immediately after they'd been diagnosed with celiac disease. So these are very much all patients you would class as classical celiac disease patients. And all of them just underwent an examination by a consultant neurologist, and they're also asked questions about what problems they were maybe experiencing. We found from this, the neurological examination results are on the left in red. 10% of them had signs of peripheral neuropathy. So this is, you know, for the kind of tingling sensations that I think Gabrielle was talking about. 29%, some difficulty in walking was noted. And 11% also had something called nystagmus, which is an eye twitch sort of sign that you can elicit in a certain way. And then in terms of self-reported issues, it matched up quite neatly. About a quarter complained of balance issues, about 42%, just under half were talking about these frequent bad headaches, and then 12% were talking about sensory symptoms. And even if we exclude the headaches, because I know that, lots of people get more headaches than they would like, we still could wind up saying that half of the patients had at least one sign or symptom of a neurological problem, which was very interesting. And then much more recently, we have re-examined 30 of these people 7 years after the fact. And what we found in this was a bit of a mixed bag, I suppose. Some things appear to have got better and some things appear more common now. So things like basically anything with a green arrow has improved over time, a black arrow has stabilized, and a red arrow appears to have worsened. The headaches appear to have sort of reduced along with this nystagmus sign, the eye twitch. The sensory symptoms and tremor, which was noted, appears stable. But then in this cohort of patients, the balance problems appear to have got worse. 27% to 47%, and then the gait, what's called gait ataxia, is essentially discussing the same sort of idea. And then also sensation in the feet seems to have got worse. What's really important to note, particularly as a scientist when we're talking about these things, are the limitations of the experiments that we do. So in this particular case, if I'm being critical of an experiment that I was involved in myself, 30 patients is not a particularly big number of people. And, it's important to look at lots of people at once, because then we can be confident that what we're seeing is really reflective of what goes on, rather than just by coincidence, we happen to look at the people who had more of one thing than another. And the other thing that's important to note with these sorts of experiments, these are people who have been invited to come back 7 years after the fact. So we could maybe expect that the people who are most motivated to do that may be the ones who are most experiencing problems. They're going to be most driven to kind of continue to engage with this sort of research. So just to finish off with, this is why it's very, very exciting to do new types of research. Beyond Celiac have recently partnered with us, and we're starting this experiment now. As I mentioned, we have these various clinics at the university and the hospitals that we collaborate with. I've written on this slide hundreds, it's over 1,000 patients we have over time, over the past couple of decades. We have multiple MRI scans from their clinical care, how the blood immunology has been going over time. So we're doing this experiment now where we're really going to be looking at the long-term progression of kind of everybody that we see, and trying to tease out from that patterns of who seems to do better, who seems to do worse, what the reasons might be for that. We're also collecting new data as well on how they perform cognitively and mood and quality of life, these things which are also clearly extremely important for someone's day-to-day experience of the world and how well they feel. So it's very exciting to start this experiment. So thanks everyone for putting up with me talking for 15 minutes. Just also want to acknowledge the other senior colleagues that we work very closely with, Professors David Sanders and Marius Hadjivassiliou, who really are absolutely instrumental to the work that our group does as well. And thank you all from Sheffield for listening. So we'll move into the panel part now. I'll stop sharing my screen. Great.
That picture of Sheffield looks a lot better than wherever Nigel is in the background. It looks at least somewhat warmer.
It doesn't look like that most days, but it does sometimes.
Well, when we come to visit, we'll expect it to look nice. Well, thank you so much, Iain. That I think was really helpful. I think so many of the questions we have are hopefully going to be answered in the research that you're doing as part of our collaboration. So we'll definitely have have to do a follow-up in a few years once you have the results of that study. So I have a lot of questions here that we collected when people registered, so I'll just start us off. So let's see. So here's the first one. So from a layperson perspective, what does it mean to have damage to your white matter? And does it always affect people in the same way? Like, do all people with neurological symptoms have that white matter damage? And does everyone with white matter damage have neurological symptoms, if that makes sense?
Okay, so there's several questions there really rolled into one, isn't there? Not everyone who has neurological symptoms from gluten sensitivity will have the white matter changes that we're describing. The white matter changes tend to be more prevalent in those who have the headaches. And the headaches actually you're more likely to have bowel involvement as well. So we need to take a step back here and just talk about diagnosis a bit more widely. So in the 1990s, we would do a test for celiac, which looked at anti-gliadin antibodies. And those antibodies are found in around 10% of the population, of the normal population. And for that reason, because it was being correlated with, at that time, classical celiac disease, it meant that they didn't match up. It wasn't a particularly good test for picking out people who, when you did an endoscopy, were going to have changes in the bowel, which looked like classical celiac disease. And so people moved on to different serological tests, looking for other antigens and antibodies. And they're specifically to something called TG2, which is an enzyme which you found in the bowel and actually throughout the body, called TG2, and endomysium antibodies as well. And those are the sort of tests that people do now, and they are much more specific for picking up people who are going to have the enteropathy. But that has kind of clouded the issue for us in terms of the neurological symptoms, because there are lots of people who don't ever get those antibodies, but still have gluten sensitivity because they have antibodies to gluten, i.e. anti-gliadin antibodies, and they have other problems such as the headaches or the problems with the cerebellum or with the neuropathy. So we clearly, there's a problem, and the problem is that most hospitals, certainly in the UK and I think worldwide, have stopped testing for anti-gliadin antibodies. Their workup of patients in this area with these problems is that you do the standard tests for celiac disease, which includes the TG2 antibodies and the endomysial antibodies, and that kind of misses what a big chunk actually of patients with gluten sensitivity. So that's one of the big areas that makes this area difficult. So that's one of the reasons why people can have these conditions and still have sometimes have negative tests, and sometimes gets missed by physicians. The other thing we need to talk about is, you mentioned about whether the reversibility so the white matter change, what we're hoping to achieve is an arrest, as Iain pointed out in his presentation. Starting the gluten-free diet, what we're hoping for is an arrest of progression. If you get reversal of changes, that is more likely to happen the earlier things are caught. The longer things go on for, the less prospect there is. The brain isn't very good at repairing itself. It's not like the gut. You know, if you take a biopsy from somebody who sticks to a gluten-free diet, after a couple of years, they're highly likely to have a completely normal biopsy when you go back and do the second biopsy. With the brain, there is less propensity for the brain to be able to repair itself. So what you see on the scan tends to stay there. That doesn't mean that you don't get a diminution, recovery in symptoms with gluten-free diet. It doesn't mean that there isn't a response to diet. But the white matter changes tend not to go away. So that's why it's really important that we try and get people diagnosed early and onto onto a gluten-free diet as soon as possible.
Yeah, that definitely underscores the reason for wanting to follow a strict gluten-free diet forever. Have you done any studies in children to see if there's any neurological differences in changes
So
or
we
any
are
symptoms?
an adult centre,
Okay.
and Sheffield has only recently become the UK's national centre for ataxia, and so we're only just starting to see the patients coming from across the country to get the numbers. I think one of the problems with the paediatric side of this story is that the numbers in the studies tend to be much smaller than what we've used in our studies, and so it's difficult to know what the strength of that evidence is. There is some evidence that for example, if you follow a gluten-free diet in the pediatric age group, about 25% of those people will be rendered completely headache-free, and the vast majority have improved symptoms. So I think that you do see this a lot of overlap. You do tend to see the same things, but I wouldn't want to go into big detail about that, because that's not something we can really comment on at the moment on our data. We don't have enough data yet to comment further.
Okay, that's fair. I mean, I think this is also a really compelling argument for making sure that people who are asymptomatic are also getting tested, and getting diagnosed. We know that that's a big group of people who are asymptomatic. I mean, sometimes they have symptoms that they just don't realize until they.
Perhaps I should share my story. So I'm on a gluten-free diet, and I got diagnosed in a very slightly odd way. So I volunteered for one of my own studies, because I thought I was normal and that I didn't have any problems, and I was just going to do a blood test to try and work out with some new versions of the tests for the antibodies how common it was in a normal population. And guess what? I turned up to have the antibodies. And then, like an idiot, I'd had terrible problems with headaches. Really disabling headaches that were happening several times a week. Very difficult to deal with, trying to get through the day, taking paracetamol and all the rest of it. Anyway, eventually the penny dropped, even for me, stupid as I am. And I started a gluten-free diet, and I get a headache handful of times a year. So, and it's interesting, the brain fog thing is something which, how would I describe it for me? I think it's lack of concentration more than anything. So I was constantly having to flip between different things to maintain concentration. Whereas, on a gluten-free diet, I've noticed that my levels of concentration have improved. So yeah, there are lots of people out there with symptoms that they're not attributing to this, and I think that's one of the areas which I think will become more important in the future. And with some of the work that Iain's leading on, I think this 10% of the population with the immunological reaction to gluten is an area which we really need to look into with far more scrutiny than we have done in the past anyway.
Yeah, that's great. Thank you for sharing that with us. Gabrielle, can you talk a little bit about how you experienced brain fog? I mean, you talked about your mom waving her hand in front of your face, but can you talk a little bit more about that?
Yeah, of course. So I think, interestingly, I think back at that time, my brain fog, it was more like I would just, like I said before, I would just be staring. Like, sometimes you see like people, like let's say you're in a classroom and you see maybe a student, maybe just they're in their own little world, right? Like, and then the teacher's like calling their name and they're like, what happened, right? Well, that's kind of how it was for me, except even when someone was telling me, like, for instance, my mom was calling my name and actually, talking to me, I wouldn't snap out of it. Like, it would be hard for me to snap out of that stare. I would just be staring, or I would just be like, I don't know, like in the clouds somewhere. I don't know. But and I had no idea either. I wasn't even aware of that, but and it would happen for a little bit of time. So it wasn't too long of a time where I was in that trance. So I would actually snap out of it, but it definitely, yeah. And the sad part I think I kind of want to share is, I was, because I had, that brain fog, issue, is that like at the time, I'm young, and, with other kids, they would sometimes make fun of me, and they would call me like oblivious and something like that. And, they would say something and it just wouldn't process. And I'd be like, what? Or something like that. And, I think that's why it, again, emphasizes how important this research is, and why, hopefully, the awareness around, neurological symptoms will help to, diagnose patients earlier. And so that hopefully they won't have to go through similar things as me, and, perhaps other patients as well.
Yeah, that's definitely true. So Nigel and Iain, I mean, we hear about brain fog as kind of an ongoing symptom, kind of a chronic symptom that pops up occasionally, but with our brain fog research, and I know you've done brain fog research in gluten sensitive people, that's more about the acute response that, right after eating, well, not right after, but, shortly after eating gluten, people are getting brain fog. Are those different mechanisms? Do we know how that works? I mean, I know that there's some kind of a gut-brain connection that that research hasn't quite figured out yet. But I guess my question is, are those two different mechanisms, or are those the same thing?
I think brain fog's a difficult issue because it's not unique to this condition. It's found in a whole range of conditions, including some other inflammatory conditions, and it's really quite common in people on chemotherapy. There are lots of reasons for which produce it, and so I'm not sure mechanistically we understand why it's happening, and I think this is a really critical part of the research effort we need to make. Is this a manifestation of having something which is inflammatory? Is it something specific to this condition? There are antibodies, we haven't mentioned them. There's something called TG6, which is an antibody produced in some people with gluten ataxia, for example, which is expressed in the brain. So there are definite targets for the antibodies within the brain, and clearly they're linked to the ataxia, the cerebellar injury. But these antigens are these targets are expressed more widely within the brain. So we haven't fully understood what the implications are for those antibodies in these patients are. So I think we have to be open-minded and say we don't really know, and we need to be willing to be open-minded about what the cause might be.
I think just to hop on top of that, I think I'd seen someone in the chat actually asking about TG6 specifically. So it's, as Nigel just said, it's kind of an additional antibody test, which we developed about 10 years ago now, I think. And slowly since then, we have more recently finally kind of integrated it fully into the routine kind of clinical testing that we do for the patients that come through. So we don't, when we're talking about this big study that we're now embarking on, where we have all this pre-existing clinical data, and we can look at all this change over time. Yes, TG6 is included in that, which is what I think the person in the chat was asking the question about. But it doesn't go back particularly far, I suppose, at the moment, compared to the rest of the data. But I think it's certainly one of the more kind of exciting edges to this. I think one of the difficult things, like Nigel was saying, I think the medical community is, they like their medical tests which are sensitive and specific, and that means that 100% of people who have a condition test positive for it, and it means that 100% of people who don't have the condition test negative for it, because these are very useful things diagnostically. And now that we've kind of achieved that for celiac disease with the TG2 and the endomysial antibodies, it's almost like the interest in it drops off. And we have these remaining antibodies, which unfortunately aren't quite so clear-cut, because they do seem to have some positive rates in people who don't seem to go on to have issues, but they also are clearly at much higher rates in people who do have gluten-related issues. So the interest in TG6 was because I think around 70% of people with gluten-related ataxia test positive for it. About half of people, or just under half of people with celiac disease test positive for it. So it's clearly relevant. The extent to which it explains the whole picture is an open question, which is unfortunately the answer to a lot of this. There's a lot of different things going on at once, but yeah, it's an interesting thing to be looking into.
So is it possible that in the future something like that would kind of be added to the diagnostic arsenal? Or, I mean, I realize it's not specific enough to...
I think, one of the things that we need to try and promote as a centre, we're unusual in that we take this condition more seriously and investigate more thoroughly than the vast majority of centres. And so that includes the availability of the anti-gliadin antibodies, the original tests. We still have that available, and we still use it widely, and that's what we use for monitoring, because it's very good for identifying ongoing exposure to gluten. We all try to keep to a gluten-free diet, but it's not always easy. And the antibodies tests are useful for follow-up. But equally, we need to include, TG6 is a relatively new test, but we've translated it into our care for patients, and there's no reason why it can't be done more widely. So we've got to try and promote that good practice. It's part of what we've got to try and do in terms of making an impact with what we're doing with the research that we do.
Yeah, that makes sense. Iain, you had talked about NAA and how on people with gluten sensitivity and celiac disease, that's lowered. And someone had asked, in the chat, if there's a potential, if that is specific to celiac disease and gluten sensitivity, or if that gets lowered in a number of different conditions.
So it will not be specific in the 100% clear-cut way that I think we would all like it to be. There's a number of different contexts to do with the brain where it gets lowered. NAA, going back a bit to my PhD here, is thought to be a marker of kind of metabolic activity within the cell. So if the cell shows less metabolic activity, or if there are just fewer cells in a given region, we will see NAA drop, for that part of the brain. So this can be investigated in cases of head injury, of kind of anything you might want to think of that affects the brain, it could potentially be affected in. But again, I think what we've been trying to kind of get at is this more kind of holistic diagnostic investigation, which, it's not so much about relying on a single test that's just going to completely answer the question. We combine the blood tests with some brain imaging, with things like NAA readings in specific parts of the brain, because that's an important part of it as well. You're not just looking at an overall region, you're not just looking at the whole brain, you're looking at a specific part of the brain that we know seems to be most affected in gluten-related problems. And then you want the right trained specialist clinician, such as Nigel, rather than myself, to try and piece all of this together and go, this looks like the picture you are experiencing. I would like to recommend for you a gluten-free diet. And then part of the diagnostic process beyond that is how do they respond to the gluten-free diet, and usually it seems to help a great deal, in our experience. I don't know if Nigel's got anything else he wants to add on to that, or...
No, I think you've answered that very well. NAA levels aren't specific, but we use it as part of our monitoring for patients. And I think the good news that it shows in those graphs that you nicely illustrated your talk with is that if you stick to a gluten-free diet, you can demonstrate a change, an improvement, a recovery of that. And if you just do the structural imaging, you tend not to see you don't tend to get that kind of information from it. So I do think it's part of just that holistic, like you say, in-depth care for patients, so they understand, that helps people understand their disease as well. You know, that feedback, it's a feedback about a positive outcome from your gluten-free diet, and it's very helpful in trying to help motivate people.
Yeah, I think that can be one of the hardest things, and but we don't really have great tools for, you know, helping people to monitor their diets, and I think a lot of people do get lost to follow-up because of that, you know, because their doctors can't, it seems like their doctors can't really do much for them after they get told to go on a gluten-free diet. Gabrielle, I'm curious about how your experiences with doctors have been since you got diagnosed. Have you now, you know, seen gastroenterologists or primary care physicians who do recognize that, or who are more likely to recognize neurological symptoms as part of celiac disease? Do those things get covered when you go for a follow-up?
Yeah, so after going to NYU, which is the college I attend, I decided I was seeing Dr. Verma before, and she was amazing. She really took care of me and was really, you know, understood and was very knowledgeable, I think, about the neurological symptoms, even when I think at the time GI symptoms were still very much at the forefront of, you know, what more people knew about. And then, yeah, so I now, I see Dr. Benjamin Liebwall in New York City, and he is amazing. He's super compassionate and knowledgeable, and really is the type of person to think outside of the box, I guess specifically in terms of these non-GI symptoms and more of the neurological symptoms. So I think he, you know, I follow up with him when I need to, like, you know, on a routine schedule. And yeah, I think that my experiences have, you know, been pretty well. I would say though, now compared to before, I think that maybe doctors, you know, hopefully with as more patients are being diagnosed with celiac disease, that it's becoming more, doctors are becoming more aware that there are other symptoms besides GI symptoms that can present themselves. So yeah, no, I think that's probably my answer for that.
Thanks. I do definitely think that it's becoming more widely known that those are also problems in celiac disease. And it's good that you have doctors that recognize that as well. So I'm gonna try to come up with one last question here. So I guess one thing to note before then, because I've seen this come up in the chat a few times, about 40% of the population, roughly, has the genes for celiac disease, but not all of those people have celiac disease. I do think there's sometimes some confusion around the genetic test, but the genetic test isn't a diagnostic test. Nigel, do you have anything that you would want to add about that?
Yeah, no, you're right. That 90% of people have a particular HLA type who've got celiac and got gluten-related neurological diseases. But like you say, the general population is quite common. The general population is 30%. But so there's clearly more to it, isn't there? And I don't think the extra bit is really that well understood at the moment. So I mean, I'm sure in due course it will become clearer. But you're right, you know, there is a discrepancy there, and it's not clear because there's like I have one of our colleagues, Dave Sanders has this analogy where he talks about people who you might have the right genetic HLA type to be at risk of celiac disease, and that's quite a big chunk of people. You've then got a group of people who have antibodies that you can detect, the anti-gliadin antibodies. And then you've got a subpopulation of those who have the full-on manifestations of it biologically, and that each group is substantially smaller than the other. But what we need to find is why some people stay in the group they're in, why people can have the right HLA type and not be immunologically reactive to gluten? And similarly, why do some people with immunological reactivity to gluten not appear to have any symptoms or signs of it?
Okay, all right, thanks. Okay, so as a kind of, Claire, do I have time for a wrap-up question?
Yes, you do.
Okay. So I think first quickly to Gabrielle, and then I'll ask a similar question of you, Iain and Nigel. So for Gabrielle, where do you hope, you know, in 20 years, you know, where do you hope that the field of celiac disease is as a patient? You know, what do you hope the future is?
First of all, I am definitely grateful that there is at least, you know, a treatment. You know, we're very lucky to at least have the gluten-free diet, something, right? But I think that, you know, I think the problem, at least for me, and I know for many others, is the worry about, you know, cross-contamination or cross-contact, and hopefully not having to worry about that anymore. Obviously, you know, I still have, you know, when I get glutened, it just completely takes me, you know, away from being able to do, you know, do my daily life activities and everything like that. And I think that, you know, I don't want to have to continue to experience that. So I'm hoping that one day there will be a treatment, you know, whether I hope it's a cure, but also even just for those in terms of like cross contact and not having to worry about that and being able to eat, you know, wherever we can and not have to worry about those small amounts of gluten exposure would be ideal. And I just also hope that the research with this, you know, with, you know, everything, you know, that Iain and Nigel is doing, like, and their whole team, I'm just like so excited and so grateful. And I hope that more research will be done, a larger sample size, and, you know, more participants will, you know, join in, and the funding for that as well. But yeah, no, I'm hoping that also more awareness as well. And I'm hoping through this, you know, conference today, you know, that will do that, you know, yeah.
Thanks, Gabrielle. All right, Iain and Nigel, I think you have your marching orders there. But where do you see this, you know, kind of this field specifically, the neurological symptoms of celiac disease, you know, where do you see that going? I know you have your own work planned over the next few years, but where do you see it going in the future?
I'll let you go first, Nigel.
No, not at all. You go.
I think a lot of my personal motivation for this aligns with everyone here. You know, it's one of these things that I think the recognition needs to be far better than it is, you know, within clinical care. So I enjoy being involved in medical research, you know, kind of with the patient in mind at the end of it and wanting that to get better. So, you know, studies like we published one a couple of years ago now, because a lot of the skepticism which often gets leveled at the research that you do is, well, you're at a very specialist center, so the patients you see aren't representative, or you know, you're kind of using all these kind of tests and mechanisms that other people don't. So, you know, how can we trust it? So we did this population study. We used population data from the UK that other people had collected and still kind of showed that these changes were happening. And I was very heartened that when we published that, it got picked up by a very large kind of international medical journal with a really good reputation. And they also wrote an editorial on it for the issue that it went out on. So I certainly think there is hope, you know, for this. I think it is a case of getting the word out there and doing the science in a certain way, which just doesn't leave people any room to kind of go, oh, but what if, and to carry on not believing it. And then I suppose the other thing I live in hope of is a day when the UK and the US use the same spelling of the word celiac, because that would make a lot of things a lot more simple as well.
It sure would.
Yeah, okay. Look, neurological complications from gluten sensitivity has only been recognized since the mid-90s. And that seemed like a long time ago to most of us. But the medical profession is a very conservative bunch. And it takes a long time. You know, it's like a juggernaut. It's got to be changed direction. And this is where I think organizations like this are so important, because we have to amplify and make more noise about what we're doing and what we're saying and what we've found already. We've already done lots. You know, there's lots of work on the immunological aspects of this condition that we've done about the importance of gluten-free diet, about the importance of the antibody tests and how they should be interpreted. And the fact that we're showing these various changes in the brain should underline to people the significance and the importance of it. And we're talking about 10% of the people potentially at risk. You know, 10% of the people of our population have antibodies to gluten. And we really have to get to grips with this on a population level, because, you know, there'll be loads of people out there who are suffering and don't realize and don't get it recognized. And there is a solution out there for them, you know, and that's what I hope. I hope we can kind of, my strongest hope for the remainder of my career is that we try and get more noise made, more amplification of what we're trying to do out there, so that that unmet need is you know, kind of met much better than we have done hitherto.
All right, now I'm butting in.
Yep, go ahead.
You all, such an interesting topic, and really something that I'm glad Beyond Celiac is elevating with this mini conference, and just so interesting. I love, Iain, I especially love the spinning brain video. I'm glad you showed us that. That was cool. But while we're getting our next set of panelists promoted, or while they're getting ready, I'm going to share another poll with you. We've just talked about, let's see, let me find the next poll. We just talked about hidden symptoms or non-GI symptoms. So I'm going to share with you a poll now. You take a look. What was your or your child's most notable hidden symptom of celiac disease? If you had, and if you have gluten sensitivity, you could also include that. And again, if you're not somebody, if you're a researcher or a physician and are here just to see who's in the audience, this will help you. We'll give this another, we'll give it another 5 seconds. I won't count out loud. I'm counting in my head. All right, last chance. Oh, all right, I'm ending poll. I'm sharing the results. So you can see, as our Go Beyond Celiac research showed, that neurological symptoms, including brain fogs, headaches, anxiety, are leading the pack. 54% of you who are participating today report those. Non-GI symptoms like dermatitis or pediformis, also that came in second at 15. Oh, no, came in third. Something else. You can tell when I put the poll together, it's like out of ideas. So sorry about that. You can type in the chat what your the something else was if you like. And fatigue. We will paste in the chat the link to the Go Beyond Celiac survey that Kate was sharing with us. It's and more research will be coming out of Go Beyond Celiac, and as more people participate and complete surveys, we'll get a more complete picture of your journey before, during, and after diagnosis for celiac disease. And that's, you can go to go.beyondceliac.org. Now I'm going to promote our folks. There's Amy. She came in. Oopsie. Pooja and Jocelyn. Right on. All right. And I'm going to turn it over to my colleague, Amy Ratner, to introduce herself and introduce her panel, and I'll turn off my own video.
Good afternoon, everyone, and welcome to our second session of the mini conference, which we have titled, You Don't Look Like You Have Celiac Disease. And it's interesting because we're going to segue from people who have difficulty with diagnosis because their neurological symptoms are not considered to be typical of celiac disease, to people who have difficulty with diagnosis because of patient demographics. And I am so excited to be joined today by two speakers. We have our patient representative, who is Jocelyn Langevin, and Jocelyn participated in our Voices of Celiac program, I'll call it, where we reached out into the community to get a much more diverse and varied picture of what people who have celiac disease look like and what they've experienced. And so we came into contact with Jocelyn through that program, and she has so graciously offered to tell us her story today. We're also joined by Dr. Pooja Mehta, who is a gastroenterologist at Children's Hospital of Colorado, where she both does clinical work and research. Dr. Mehta is also a member of our advisory board for a very exciting program that we're doing at Beyond Celiac, which is designed to look at the demographic spread of existing celiac disease, and then an attempt to determine or get some evidence about where we might have missed diagnosis, that is, people who have not been diagnosed at all, or people who have been diagnosed with something else other than celiac disease incorrectly. And so I believe we're going to start off with Jocelyn telling us her story this afternoon. So welcome, Jocelyn.
Hello, thank you so much for having me, Amy and team. I'm really excited to be here and to share my story. You know, I can actually go back to when I was a child. You know, my mother would always use the term and say that I had a sour stomach, right? A kid who always had a stomach ache. Doctors would diagnose me with a stomach bug at least once a year. And I look back and realize that that stomach bug just wasn't that. You know, I'd get terrible stomach aches when I had things like sweets and pizza and all the things that kids love. But those foods just made me feel worse. And when my parents took me to the doctor, it was always brushed off, right? Eat more fiber, drink more water, exercise more. Fast forward to adulthood, where I learned just to avoid the foods that didn't make me feel well, which worked to an extent. You know, every few years, the symptoms were pretty unbearable, and I'd go to a doctor, and they would connect those symptoms to something else. Right? Pain in my stomach became, you know, ovarian cysts. Bloating was, I need to drink more water and eat more fiber. Acne was, you just have adult acne. My anemia, my low vitamin D, you know, you should take supplements and eat the foods that support those vitamins. The turning point, I think, for me was in my late 30s, the symptoms became more intense. While I had kind of convinced myself that this was just going to be my life, like I had a sour stomach, right? Doctors, you know, would continue to just connect my stomach issues with things that weren't really relevant. Like now in my late 30s, it was, you know, you're getting older and you just can't eat the same way that you did in your 20s. One doctor literally said the words to me, I understand many of your cultural foods are fried. Perhaps you should cut back on those things. And by that time, I didn't eat meat. You know, I was leaning more towards a plant-based diet, which I explained, and he smiled and he nodded, and he sent me to the drugstore with things like Miralax and Benefiber, and told me, you know, it was caused by all of those things. You know, I really remember feeling somewhat helpless and enraged, but then began to kind of do my own research. And it wasn't until kind of early 2020, just as the pandemic hit, my symptoms had hit really an all-time high. It was really terrible. You know, I tried a new gastroenterologist days before the shutdown, which of course gave him something else to blame, right? The stomach issues were likely stress-related to the pandemic, and I should exercise and cut back on wine and fatty foods. He told me I should actually come back when they were doing electric surgeries, you know, when those resumed, to have a colonoscopy and endoscopy just to see. but he didn't feel it was emergent, so he couldn't do anything right now. And maybe down the road we could. You know, I think that was like the match that lit the flame in me personally. And it was at that point that I had had enough. But because of the pandemic, my hands were tied a little bit, right? Most doctors' offices were only seeing emergent patients. So I turned to the internet. I don't suggest that all the time. You know, I Google search things like, you know, symptoms misdiagnosed, gastro symptoms misdiagnosed for, you know, Blacks and Hispanics. You know, I dedicated some time to also researching a new gastroenterologist. I specifically wanted to see a woman of color. I wanted to really feel seen and to be heard because I had reached the point where I couldn't live with these symptoms anymore. You know, I did find someone, she's about an hour away from me, you know, but I scheduled the first in-person appointment that I could get in 2020, again, amidst the pandemic and all the other things going on in the world. You know, I remember vividly that day, but I had a few weeks prior to that had found an article on medical racism, and there was a script in there for people of color that they should use when they felt the doctor was ignoring their request. You know, I felt a little defeated having to do this, but I was prepared, and, you know, I felt equipped to have the conversation. You know, as soon as she walked in the door, I remember, you know, I said, I've been ignored by white doctors. I've been suffering with these symptoms for most of my life. You know, I want to be tested for celiac, Crohn's, and everything in between. I want you to perform a colonoscopy and endoscopy. I want a full workup to identify what the issues are. You know, I went through my symptoms, obviously. You know, I told her I drink 90 ounces of water. I don't need more fiber. I just want to be heard, and I want my wishes respected. And if you choose not to perform these tests, I would like you to note it in my chart that you refuse. And I paused and I waited, right? And she placed her hand on my shoulder. She's so sweet. And she said, I'm not refusing. I absolutely think we should run these tests and see what's going on here. I left the appointment, you know, scheduled the appointment. I left at the doctor's office. I got into my car and I bursted into tears, called my husband. I don't know anyone who was like so excited for a colonoscopy in their lives. Like I was like ready and fueled and ready to go. They found out that I had celiacs and ileitis. And, you know, sadly, I felt relieved by my diagnosis. It gave me a sense of relief. I immediately cut all gluten out of my life, you know, which was a huge undertaking, and I felt very overwhelmed by it. But I made the adjustments and saw a huge improvement in my symptoms in just a few weeks. You know, it's sad to me that so many, when Beyond Celiac posted my story last year on Instagram, so many people said they had the same story and they felt the same way. And it's so sad that so many people have had to go through this. You know, I went 30 something years, you know, kind of in that same boat, but, you know, took that time to advocate for myself. And because of that was finally diagnosed properly and finally heard. And, you know, now I have a great medical team behind me, but it took a while to get there. But I'm happy that, you know, we finally have gotten there.
Jocelyn, thank you for sharing your story. And you are right that as we sought out stories from people of color in particular, we heard the message pretty loudly and pretty clearly that getting a diagnosis is an additional challenge to that faced by people who fit sort of a standard picture of celiac disease, which is that it's a white middle-class, or I'm sorry, white middle-aged woman's disease. That tends to be the picture of celiac disease that's out there and is often reflected in the kind of study participants that are enrolled in clinical trials. But we did hear from the community that this is an issue. And so it makes diagnosis harder if you are a person of color. And that sort of bolstered a project that we were already working on and that we had started to talk about more than a year ago, almost 2 years ago, where we wanted to look at and start to develop some evidence about what is the true picture of celiac disease in the United States, looking at it and combining that with demographic information. And so we set out with the National Minority Quality Forum, which is an organization that works in the areas of healthcare disparity. We partnered with them to map celiac disease across the United States in an effort to uncover and address disparities in both celiac disease and non-gluten sensitivity. And the idea behind this is we don't really want to just map it for the sake of having a map, although the maps are pretty cool, I have to say. But we did it because we want to drive diagnosis and care. And there is a lot of discussion in the research world and at the level of the NIH and the FDA about improving diversity in clinical trials. Now, we realize that there is a bit of distance between these two things. In other words, you have to first make sure that people are getting diagnosed so that they know they have celiac disease and make themselves available for clinical trials. But when we started to work with NMQF, how the project is set up is that we're analyzing Medicare and Medicaid claims that are related to celiac disease and non-celiac gluten sensitivity. And what we're looking for are insights on incidence and geographic and demographic distribution of these conditions in the United States. Part of this project included creating a diverse board of advisors with expertise in celiac disease. And so when we talk about a diverse board of advisors, what we meant by that is we wanted celiac disease experts who were at various stages of their career, who represented various gender, various ethnicities. And we were very fortunate to have Dr. Mehta agree to be part of that group. And she'll be talking a little bit later about both her experience in that project and also the kinds of things she's seen as a clinician working in two pretty different kinds of medical facilities. And we think that'll be interesting and insightful. But so what we did with the input that we got from this board of advisors is start to look at ways that we could examine the gaps and the disparities and the misdiagnosis and more. And that advisory board, in their review of both the project that we have going and bringing into play what they know through their clinical and research experience, they concluded that race, ethnicity, age, and gender can all cause delays in diagnosis, or worse than that, a failure to diagnose at all. So the project is still ongoing, and we are still putting data into this system that we're using that NMQF developed. And kind of a short description of how it works is that when someone sees a doctor, and in this case, it would be someone who is getting Medicare or Medicaid health insurance coverage, their doctor codes their visit or their claims, and then those codes are used to create a record of what happened in that medical visit. So we looked at the beginning at data from 1 year of Medicare records, and in that data, we found 70,000 patients in this 1 year of Medicare data who had a celiac disease diagnosis. And we've recently added the second level of Medicare coverage, which is Medicare Advantage, and that has shown us an additional 15,000 people in this 1 year who have these medical claims. Medicaid records from the same year show about 38,000 patients with celiac disease. And when we broke those numbers down, or when we break those numbers down by race and ethnicity, when you're looking at that 70,000 in the 1 year of Medicare records, 65,000 of those people are white, and these are rough numbers, but roughly 65,000 are white, and 2,000 are Black. When you look at Medicaid, of the 38,000 patients, 23,000 approximately are white and 2,000 are Black. So we start to see that there are the percentages and the numbers are giving us some insight as to where some of the issues in the area of healthcare disparity might lie. So the other thing that we're doing with the project is we're looking at symptoms and comorbidities that could potentially indicate when someone should have been diagnosed with celiac disease and wasn't. And these symptoms and comorbidities that we have worked into our system were identified by our NMQF advisors. And so when we did this, we start to see potential healthcare disparities. As an example, in the Medicare data, when functional abdominal pain and osteoporosis were looked at in combination, there were 348,000 claims compared to 70,000 claims indicating a celiac disease diagnosis. And about 25% who had those two conditions that advisors identified as potentially indicating celiac disease, but it weren't diagnosed with it, are non-Caucasian. So, the other thing that we can do with this system is we can map out where we're finding claims geographically. And in areas where the numbers are higher, we get a bright red color. And in the numbers where they're lower, we get a yellow cover. And so when we looked at the maps of the geography of where celiac disease patients are found, compared to maps where patients with potential symptoms of celiac disease but no diagnosis are found, the maps were practically flipped. So those with celiac disease were found largely in the Northeast and Midwest, while those with potential symptoms were largely in the South. And early analysis of some of the data that we're collecting on other combinations of symptoms shows similar patterns in Medicaid. So ultimately, what we're trying to do is create a unique resource to increase awareness, improve clinical practice, expand research, and improve the health outcomes for patients with celiac disease and non-celiac sensitivity through this project. The next steps, we will be adding more years of Medicare data and gluten sensitivity in the US. And we're hoping that through the combined science and the advocacy power of Beyond Celiac and NMQF and the tools being created through this partnership, that we will be able to drive multidisciplinary research collaborations. We hope to help accelerate clinical trial recruitment efforts, increasing diversity and participation, and to inform initiatives and policies aimed at improving equity in the diagnosis and management of celiac disease and non-gluten sensitivity. One of the things that we've also done as we've looked at the data that we have, or the data that we have, is we can do overlays. So we can look at where diagnosis is and isn't, where potentially misdiagnosis isn't in it. And we can overlay that with census data and other kinds of data. And so the ultimate goal that we have is to collect evidence out of this kind of data analysis. And then from there, and we hope that this evidence can also influence researchers who are studying celiac disease to potentially come up with studies that address some of the issues that exist for those who don't fit a really very standard definition of what celiac disease is, in the same way that Nigel and Iain and our patient representative were talking about earlier, where someone doesn't fit the standard definition because their symptoms are not gastrointestinal, they're neurological. So we're coming at diagnosis, this is just from a different direction. This is looking at it from the standpoint of, you can look a lot of different ways. You can be male or female, you can be young or old, you can be black or white, and you can have celiac disease. So that, in summary, is what our Beyond Celiac and MQF project is about. And we can answer some questions about it and talk about it later when we get the panel discussion going. But now I'll have Dr. Mehta talk to you a little bit about her work and also introduce herself to you more extensively than I did.
Hi, everyone. Thanks so much for having me today. Thank you, Amy. And Jocelyn, thank you for sharing your story. I think we need to hear more stories like that and get our voices out there. My name is Pooja Mehta. I am a pediatric gastroenterologist at Children's Hospital Colorado. And I am also the only pediatric gastroenterologist at Denver Health Hospital. Amy approached me about participating in the NMQF Beyond Celiac collaboration because I have a real interest in kind of addressing disparities in diagnosis, but also because of my work at both of those hospitals. At Children's Hospital Colorado, I'm part of the Colorado Center for Celiac Disease, and we are a large tertiary care center that really cares for most of the children with celiac disease in the state of Colorado, but then also branching out into some rural areas like New Mexico or some of our surrounding states. And then I also work at Denver Health. Denver Health is Denver's community hospital, which really cares for most of Denver's underserved population and cares for most of our underinsured population as well. Denver Health really cares for a broader or diverse range of patients and also has specialty clinics such as Denver's refugee clinics. So through my experiences at both of those places, I've really seen a lot of patients with celiac disease, which has really cemented the way we approach celiac disease in general as physicians. I think really needs to be broadened, whether it's like the neurological symptoms that we talked about in the earlier session, or just, someone doesn't have the right ethnicity that you might think of with celiac disease, or someone comes from the wrong income. And so I think a project like the NMQF study is something that's really needed. I personally am also a health services researcher, aside from being a pediatric gastroenterologist. So I have a master's in clinical sciences. So it's exciting to be part of such work like this.
Thank you, Pooja, for sharing that with us. We did get, as Claire has noted several times, a number of questions from the attendees in advance of our getting together. And so we can answer some of those in the course of having a panel discussion. So, Jocelyn, when you think about what it is that would make the biggest difference in terms of someone who of color who has celiac disease, is what would be the things that would come to mind for you? What are the areas of biggest concern? What would be the most helpful kinds of steps?
Yeah, I think the most helpful kind of steps would be for doctors, gastroenterologists specifically, to have an awareness and be positioned and have received training in a way that allowed them to see beyond someone's skin color when diagnosing something like celiacs, right? I've been told many times that I don't fit the profile. It's not prevalent in the Black community or the Hispanic community. And it just wasn't something that people were looking for, right? They were looking for all of these ancillary things that were wrong with me, or just brushing it off altogether. So for me, I think it would have been helpful years ago to have a doctor kind of stop and say, you know what, this sounds like this. It doesn't matter that you don't fit the profile, whatever that means. This is something that we're going to explore, and this is something that we should discuss, based on just your symptoms. I look back and I had all of the symptoms. I even had some of the neurological symptoms specifically, but it's funny because the timing of that was also around the time that I had just had my daughter. So it was also blamed on something else, right? It was the mommy brain fog versus like it being tied to celiac. So it was always replaced with something else. So for me, I think the biggest difference and the biggest help in all of this would be the first stop is always the doctor's office. So I think the first stop needs kind of the proper training to be able to deal with people of color when diagnosing something like celiacs.
And Pooja, do you think that how does that happen? Do you think that it has to come out of evidence that celiac disease is not non-existent in people of color. What from a clinician's point of view, how does the thing that Jocelyn says we need, how does that happen?
Yeah, I think there has to be a lot of avenues for this to improve. One, as physicians, we are really kind of hierarchical, and we're trained by our prior physicians who, teach us one thing. And so there has to be kind of a broader outreach to physicians to say, hey, maybe what you thought you knew was true is not necessarily true. And then, of course, research studies. The more research that there is to support what patients are saying and what providers who might be caring for a more diverse population are saying, the more you can combine those, the better. Something like this forum where we're actually talking about it. If we don't talk about these questions, then we're never going to have the right answer for it. So I think even bringing it up, some people will even say, well, is this even an issue? But if we don't even talk about it, we'll never know.
Mm-hmm, mm-hmm. As someone, Pooja, who has gotten a glimpse at the project that Beyond Celiac and NMQF are doing, do you have any thoughts about what it potentially might be able to tell us, or how it might be able to help in regards to changing the situation in terms of diagnosis in a diverse community?
Well, the ultimate hope would be that we would diagnose probably, the thousands of people who are walking around with celiac disease and don't know it. I think the project itself was great in that it brought people, the advisors were from different parts of the country, different backgrounds, different practices, and so that we could all put our experiences together to try and understand who are these people that could potentially have celiac disease, and then not even be screened for it or not even be tested for it. And so that's where I think the project has a lot of potential to really say to the medical community, like, hey, look what you did. You didn't diagnose, you didn't even test these people. And when we see that data, then it provides the next step. Okay, well, what happens if I do test all of these people who just looking at symptoms, regardless of their gender, their race, how many people would have celiac disease? And then ultimately try and create some interventions to prevent that from happening.
And I think that because you do clinical work in two very different kinds of atmospheres, can you tell us a little bit about what you see that's different that would relate to diversity in many ways, socioeconomic issues of gender, race, that kind of thing?
Yeah, I think, and I don't have data on this, so hopefully I'm not saying the wrong thing about the two institutions, but there are a lot of people, physicians of color, nurses of color who are working in Denver Health, and there are at Children's Hospital Colorado as well. But I think just being surrounded in an environment where you might see someone that looks like you, a physician that looks like you, might make it more comfortable for patients to really talk to you, kind of like Jocelyn said. She sought out a physician who was Black because she wanted to talk about this. And there have been studies that have shown that people feel more comfortable talking to someone that they can relate to with regards to patients and physicians. So I think that is important. And then there's a large Hispanic population at Denver Health, in Denver in general, but just having exposure and testing patients and seeing patients from a diverse background really changes how you practice medicine. If you don't really interact or see patients who are different, then you'll never know what you aren't looking for.
Mm-hmm. And I think, so both you and Jocelyn, you had also mentioned that it was important to you to find a physician of color. I don't know if you were talking about a your primary care provider or your gastroenterologist. We do know that there is a shortage of gastroenterologists of color just nationwide. But I guess one of the questions that we had gotten from the audience is, why is that important? And I don't know if you can expand on that a little bit, and then Pooja, maybe if you want to weigh in after Jocelyn says her piece.
Yeah, so Amy, thank you for that question. And to clarify, it was both, right? I found a woman of color as my new PCP, and then also for gastro as well. And finding one was definitely, finding a gastroenterologist of color was a needle in a haystack in the state of New Jersey. It was not very easy. It was not a seamless process, as I'd hoped. As I mentioned, I live in central New Jersey. My doctor is almost an hour away in northern New Jersey. So that was quite a challenge. Why was this so important for me? Honestly, it was a little bit of a process of elimination, right? I had seen primarily white doctors, male doctors, and I was like, I need to see someone different. Like, I need someone to hear what I'm saying, to understand, and to feel comfortable enough to have a very open conversation that I had felt that I had experienced, neglect is a strong word, but had been ignored for so long with these white male doctors, that I wanted to be able to have an open dialogue with my doctor, and also feel like my doctor understood me culturally. Someone in the chat mentioned cultural competency. And I thought that was very important to me for gastro in particular, because I had seen a doctor who'd literally said, your cultural foods are usually fried. That was, such a microaggression. And so such a terrible conversation for me or any patient to have, that it scarred me a little bit. And it made me want to only seek doctors. And listen, I have a mixture of doctors across different specialties, but for this in particular, it made me want someone of color who I felt understood me culturally, and I'd be able to have an open dialogue with.
Pooja, what are your thoughts?
I would agree with what Jocelyn said. You just want to be comfortable with your physician, and it doesn't necessarily just have to be race or ethnicity or language. I think we just need to broaden our healthcare force in general, whether it be, coming from different socioeconomic status. But when we have different backgrounds, we're able to relate to our patients better. We're able to find a physician that you can relate to in whatever realm. As in terms of, I guess what the research has shown, besides people finding more comfort in talking to someone who might understand their culture better, but there's also some research that's shown that if you are from a minority background, you're more likely to serve as a healthcare provider in an underserved area. So I think, beyond just that one-on-one patient interaction, there's broader implications for just, public health in general.
Someone asked a question that I think really sort of gets to a bit of the heart of the issue of healthcare disparity and celiac disease in particular. And what they wanted to know is, why is it that doctors assume that celiac disease doesn't affect people of color?
I think that's a hard question. I don't think people are intentionally, for the most part, I would hope that people are not intentionally trying to alienate their patients. But we do. All of us, all physicians will make a mistake and we will have bias. Everybody does. And so I think there's a lot of bias in how we've been trained, what we've been taught. And I think hopefully that's changing now as we're doing more research. And the publications that we've had, there's not been many in terms of celiac disease and just the broader population that it affects. So I think as we do more research, we'd be better able to really understand why doctors think this way. And not everyone, but why it seems to be a common theme that people are feeling.
I do think that is one of the things we're hoping that will come out of our work with NMQF, is that if we can, start to show actual evidence based on race and gender and ethnicity that can help. Someone else had asked, what kind of research has previously been done in relationship to celiac disease and Blacks in the United States? And so I was looking around a little bit to see what that research looked like. And it seems that most of the research that exists has been sort of a search to kind of determine what the prevalence is. And in general, you know, we think of, I think it's all, there are variations, regional variations, but in general, the figure that's always used is that celiac disease affects about 1% of the population. And so there have been some attempts to see if that number within the Black community in the United States can be nailed down. And I guess my summation would be that it has not yet been nailed down. And part of the reason I think that has been mentioned in studies is that you can't know what's there if you don't know it's there. And I think earlier, I think it was Gabrielle had mentioned Ben Leball, and Ben Leball has done some work in, who is a researcher out of Columbia. He has done some work in this area, and he talked about it as being kind of like a cycle. You know, you can't find what's not, if you don't know it's there, you can't find it. And then if you can't find it, you don't know it's there. It's that kind of thing. But I think the most recent, there was an interesting study in 2021 that came out of the University of Chicago. And what they looked at, what they concluded in their study, which admittedly did have a fairly small sample size, but they did find out that Black race and public insurance were associated with not having the appropriate workup for either irritable bowel disease or celiac disease when someone has symptoms of iron deficiency and chronic diarrhea. So that's exactly the kind of thing that we're looking at in the NMQF project. We're looking at people who have codes for those conditions and then seeing whether there's any mention of celiac disease or not. So I thought that was an interesting way of what is actually out there right now. And mostly it is related to what I would call prevalence. So there might be some, well, let me think of this question in another way. Is there a way to explain why it would be important to all people with celiac disease, for all people with celiac disease, regardless of their race or ethnicity or socioeconomic status, to be diagnosed? And Pooja, do you want to take a crack at that?
I think the more people that we know have it, the more people that participate in research studies, and the more that we understand about the disease in general, the more likely we are to find more treatments, to understand how it affects our life. And so we always want to mimic our research with real life. And so if we don't really know what real life is, then our research is always going to be inaccurate. And so I think, Amy, one of the things you mentioned about research studies and just if we're not looking for it, we can't find it. At Children's Hospital Colorado, I'm really lucky to be part of a really robust research group in celiac disease where we're doing a lot of screening studies. So we take out that bias in terms of who is actually getting tested. So we have a better sense of, okay, if we don't require a physician to screen and test you for celiac disease, we might have a better understanding of how it affects all different races, all different socioeconomic status. And one of our studies, the ASK study, we've screened over 30,000 children in the area. So it's just a booth. If they want to get screened, they can get screened. And, almost half of our patients identify, or half of the people who have been screened identify as Hispanic. So we know that people want to know if they have celiac disease or not.
Mm-hmm. And so I'm thinking about if you are someone, and Jocelyn, you kind of have a roadmap because you've done it yourself, but what advice would you give someone who, a person of color who is having difficulty with diagnosis based on, having the symptoms and thinking this might be the road. What do you think were the most helpful things or the most important things that you did that enabled you to get past that barrier?
Yeah, sure. So first of all, I was really good at charting my symptoms, right? So writing down exactly what I was feeling, when I was feeling it, to try to, have some information and data to bring to my doctor's appointments, right? I didn't just want to go in and just say, I don't feel well, or I have a stomach ache, or this hurts, that hurts. When I do this, this hurts. No, it was very specific. On Tuesday, I ate this and this happened. And while that is not ideal, it doesn't have to be so, specific and clinical. Like everyone walks around with their phone, like you can jot it down in a note and just take it to your doctor just so that you have very specific information. That was very helpful for me. I think secondarily was also just advocating for myself, right? I didn't let it stop. Like I wish I had done it earlier. But it wasn't something that I just stopped doing, right? I didn't just take it on the chin and live with the way that I was feeling. I made sure that I found a doctor and found my voice, right, in my journey, and found a doctor that worked for me and really put in the work to find someone that cared about me as a holistic person beyond the color of my skin, to be able to find the right diagnosis. So advocating for yourself is one. And I think, just jotting down everything that you're feeling, when you're feeling it, how you're feeling it, how it changes throughout the day is another great tool that I would tell people. Because, some days your symptoms change and some days you feel fine, and, that's great. And those are your good days. And then some days you have really bad days and some days it's just a bit in between. So just kind of charting that so that you have a record of that and are able to share it was really important.
And I think, that advice could apply to anyone really who's having trouble with diagnosis. And we do know, when we look at the numbers and earlier in the mini conference, someone had referenced, it might have been Salvo, that overall, the diagnosis of celiac disease is underdiagnosed. And the rate is thought to be, it's a wide range, but it's somewhere between the number of people who have been diagnosed is somewhere between 17 and 50%. That's a pretty big range. But so, your advice could apply really to anyone who's struggling with getting a diagnosis. Pooja, can you talk a little bit about how the social determinants of health might impact the diagnosis of celiac disease, and maybe describe what those are and how they would impact?
There's kind of been newer research in this, which is great. I'm really excited that people are looking into how, the communities we live in, our race, our gender, our income, our education, how all of these play a role in our health. And with regards to celiac disease, there are some recent studies that show that they do play a role. We know that in kids who come from a lower socioeconomic status, that gap in how many people we think are not being diagnosed is growing. So if you are from a lower SES, there might be you might be more likely to go undiagnosed than someone who is from a high income area. Similarly, I think we're trying to figure out, how does access to care affect your diagnosis? If you live in a rural area where there is no pediatric gastroenterologist, are you more or less likely to be diagnosed? And then in the actual nitty-gritty practice of medicine, for example, I think one study showed that if you were, that white patients got more biopsies during endoscopies than patients who were Black for symptoms that could be celiac disease. So I think all of these little things combine to show us that, our ability to diagnose any medical condition goes beyond just that one-on-one interaction, but it really reflects kind of society as a whole.
Right, and I think there was a study, it was done in 2012, that did show that there is a disparity in even when someone gets an endoscopy, if they're African American or Hispanic, there's less likelihood that a biopsy will be done. So you could imagine, with the biopsy currently being the gold standard for diagnosis, how that would have an impact. Do we still have Jocelyn, or did we lose her? Is she still here? Okay, maybe we did lose Jocelyn. I'm not really sure. But one of the things I was going to ask her, and I can maybe expand on or talk about a little bit myself. I had participated in a conversation where a diverse group of patients were brought together, and they were talking about the idea of advocating for yourself as a patient, and describing how incredibly difficult that is, in particular if you are if you come from a minority population. So that the the average person, I think, is a little bit intimidated when they go into the doctor to really advocate for themselves. And in this group of people from a variety of different minorities, they talked about how almost breathtakingly intimidating it was, and that they had like one goal when they went to visit their doctor, which was get me in and out of here as fast as you possibly can. And so they wouldn't ask the follow-up questions they really wanted to ask. So I think that if that's facing you, no matter what your situation, probably having those questions written down is helpful. And then you can just like tick them off, and that way you won't have that flight feeling before you get through everything that that you want to ask when you're visiting your doctor. So one of the things that the NMQF project looks at, as Pooja knows, is geography. And we had noticed, well, maybe I can get you, Pooja, to talk a little bit about what those initial looks at the data from NMQF were revealing about geography, and how you reacted to that at this early stage. We know there's still a lot to do, but I just wondered at this point what you would say about it.
I would say it's not surprising. I mean, it's both surprising and not surprising. I'm not, one of the things that we discovered during the NMQF, just looking at the data, was, for example, Michigan has a large proportion of people with celiac disease who come from, their heritage might be Middle Eastern. And if you are, if you know kind of the global prevalence of celiac disease, we do know that there are pockets across the world where there are high rates. So for example, North India, North Africa. And one of the things that someone brought up during, I can't remember which advisor it was that, for example, if you identify as someone from the Middle East, you check Caucasian on the boxes for research. And so I think just looking at the distribution of where people live in the US and comparing that to how we categorize race in this country is really important. And it kind of brings up the idea that, race as we categorize it in a lot of the questionnaires we do is not necessarily indicative of our genes. And so I think looking at the geographical distribution in the country will help us understand that, and help us understand where these pockets are that we can intervene on in terms of educating physicians, educating people to look for celiac disease.
Mm-hmm. So one of the things that, we started to notice is a little bit of more of a concentration of celiac disease diagnosis in the Northeast, in the Midwest, less so in the South. I guess it's a little early to speculate on that, but I guess, do you think that the existence of a celiac center is critical in diagnosis, no matter, particularly for a diverse population, but for everyone, really?
I think for many reasons, having a celiac center is important. One, because as you know, celiac disease goes beyond pediatric gastroenterology, right? And providing that multidisciplinary approach can sometimes be really helpful for patients. There have been studies in other diseases that show that access to tertiary care or like specialists is also dependent on race, where someone might be referred to a specialist more likely if they are white. And so, of course, if you have easy access to see a specialist by yourself, I think it allows for people to advocate for themselves. And I think all of these factors are really important, and part of the reason that I don't think we can say based on the data that we have, but I think looking into it and trying to better understand it is going to be really interesting. And I'm excited to see what we can learn with this data.
Right. I think that's the direction that we are heading in. And we've talked a lot about disparities in race in celiac disease diagnosis, but there is also a tendency for women to be diagnosed more than men. And so when we break down the data that we have, we can also look at it by gender. And maybe another outcome of the work that we're doing, if not directly, indirectly through creating evidence, might help to even those numbers out a little bit too, would be my. So I don't know, we think that maybe Jocelyn had some computer problems. So Pooja, I don't know, is there anything that you want to say in summary?
In summary, I'm just excited. I'm excited that we're asking these hard questions and that, you know, the celiac community is kind of coming together and joining forces with researchers, and that we're all really working together to answer some of these. And so I look forward to seeing what we learn.
Great. And thank you for joining us both today and in that broader project that we're working on. We appreciate your perspective and your out of the box thinking and all of those things that you bring to the table.
I noted in the chat there's some comments about some systemic issues like access to healthcare or access to private healthcare as a barrier. One person mentioned having your healthcare through the military. Either didn't specifically name the VA, but if you're in the military, you have healthcare through the military, and a reluctance there to be diagnosed. Any thoughts about that before I let you go?
Yeah, I mean, I think everyone is spot on that this is part of a bigger issue about healthcare and how we provide healthcare. And so I think all of that is very important, and I commend everyone for thinking about it and bringing it up, and hopefully kind of encouraging more researchers to start looking into that, because these are hard questions and hard answers, but I think all of those are relevant and important.
Very good. Well, thank you so much. I'm gonna move you. There you go, off. Oh, Amy left. And then there we go. Now it's just me, my big old head right there on the screen. So thanks everyone for continuing to participate. Our numbers are still really great, and the information is wonderful, and I will convey to Jocelyn all of the appreciation that you all have been sharing, as well as Dr. Mehta. I have one more poll before we start our third session, and it is about whether or not you had a doctor who told you you probably didn't have celiac disease. Did a doctor ever tell you that you or your child, if it's your child, probably didn't or couldn't have celiac disease even prior to testing? Not to skew it, that happened to me. I had a GI doctor. I had positive blood work, and it was going for my endoscopy and biopsy, and the GI's like, "You don't have celiac disease." I'm like, my numbers. He's like, "Oh, I guess I'll do a biopsy." He's like, "Yeah, think." All right, we'll give you just another minute or less, not a minute, doing my mental countdown from 5. All right, we're going to end the poll, and I'll share the results. There you see it. 2/3 of the people on this call, on this webinar, we're told by a doctor at some point, oh, you or your child couldn't have celiac disease. And so we know, and we've heard regularly, that physician education is a big part of the work. And the way to get the attention of physicians is through published research. And so while doing physician education, hey, doc, it's important that you know these things is one way to educate doctors. The other is to get in front of them with published research and papers and that sort of thing. And I think that some of the questions in chat about what we're doing next with our research into racial disparities, we're just, it's the NMQF partnership and the mapping project identifying where there are misdiagnoses is just one step in that process. But we are definitely going to disseminate that information and get it out there in a way that doctors and other researchers will take note of, so that we can, work to make this better, get people diagnosed, get people on the gluten-free diet as quickly as possible, given the research that we saw about brain damage. And also, to support clinical trials, we need an accurate representation of the entire celiac disease community to participate in clinical trials, so that we get meaningful, in the word is, or meaningful endpoints, which means, let's come up with treatments in addition to the gluten-free diet that will address some of the topics that we're talking about, not just GI, but also the neurological and gut-brain issues. So we're coming up on session number 3. We actually did have one of our participants had a conflict, and so we pre-recorded it, and I'm going to play that recording. The chat, of course, will remain live, and we'll continue to respond there in the chat, and I'll pop back on at the end with some final closing words for our session today. So this just in, apparently the audio is not working on that video, and that's a shame. It was nice and loud in my basement here. I am not sure how to solve that. So I'm going to invite the panelists who are still with us, my colleagues, Amy, Kate, Maria, Alice, if you're still with us, Salvo, if you're with us. If you turn on your screen, we'll just have a wrap up discussion, and we will make that video available online and share with you. Instead of trying that again, I think let's just have a conversation now. This current computer it can have some issues, and so we will absolutely share that video, and it's an excellent conversation about the future of diagnoses and using the pill capsule for diagnostics, and research from Isabel Hujol in terms of the TTG test, getting a negative TTG test, not necessarily being an indicator of an accurate indicator of whether or not you should get an endoscopy and biopsy as a follow-up. So first, and I know I'm putting everybody on the spot, but I wanted to first ask Salvo, what are your reactions from the conversations you've heard today? What came to mind? How does this affect your thinking about celiac disease and your work as the Chief Science and Strategy Officer at Beyond Celiac?
Yes, Claire. Well, first of all, the powerful testimonies of both from the people affected with celiac and so on, if anything, reinforce I guess my feeling both as the chief scientist, as a patient advocate, that so much more work is needed, and that we are really going in the right direction in terms of putting a lot of efforts in unhiding really the non-GI manifestation of celiac disease. It's heartbreaking for me to hear all these stories, and again, none of this is new to me. I've been going through this myself with my daughter. So I think that the work that the Sheffield group is doing is quite important. I'm glad we had an opportunity to fund it, but more needs to be done, as we hear, in building awareness about the physician community, about the fact that, you know, this is not just a, you know, bellyache, a GI disorder. And I think that it requires coordinated effort by us, but also by others, right, to make sure that we unhide the wrong perception that this disease is a white person disease, that this disease is a GI disease, and so on. So that to me is the takeover. If anything gave me like going back to, you know, guidance and reinforcement, that this is an important area to invest in, and we are going the right direction.
Alice, how about you? As the CEO and, you know, our leader for almost 20 years now, and first raising awareness. The organization was, you know, originally founded to raise awareness at the, you know, in 2003, when you founded the organization, it was estimated only 3% of the people with celiac disease were diagnosed. We've definitely moved the bar on that. There's a long way to go, but the organization has pivoted to research for treatments beyond the gluten-free diet. What thoughts came up for you as you watched the conference unfold today?
Thanks, Claire. Thanks, Salvo. Well, first of all, I just want to thank, you know, all the panelists, all the team for putting this excellent conference together, because I think it was what we heard from some of the participants, how thankful that they are that, you know, we're sharing not only the research, but that we're bringing to light, shedding a light, as Iain had mentioned, on the fact that, you know, celiac disease is a serious genetic autoimmune disease. So that's really my first take-home point with all of this, was the fact that, you know, it's serious, right? It's not, and the gluten-free diet, secondly, is not sufficient. And, you know, and by our funding the work in a multi-dimensional approach, you know, Salvo put together a science plan that really looks at funding translational research and picking the right research that will translate from the bench to the bedside, so that we have treatments, but we also at the same time have to concentrate and some of the resources and, you know, raise money to ensure that our entire community, which was brought out in the second session, is properly diagnosed, right? That everyone needs a proper diagnosis. And, you know, and there's a lot of work to be done. At the same time, I'd say we always have to applaud our accomplishments, right? We've got to think of how far we came. And as a leader, I'm always like, we have to do this, we have to do this, we have to do this. We have to keep, you know, raising more money and funding more research. At the same time, we have to know how far that we have come in this field. And we have some incredible researchers, you know, around the country, and incredible centers. And I noticed that, you know, we pointed to a handful of great key opinion leaders that we all know. You know, my hope for the future is, when we talked about the medical professionals, that every physician can recognize the signs and symptoms of celiac disease, so we no longer hear these stories, and the stories are of the past. Of course, we want to hear the patient voice, but we don't want to hear these arduous journeys. And you know, I'm hearing hope, and I know that with the funding that we put forward and others, that we're going to make real progress.
So Alice and Claire, can I make just another comment? I was thinking about this when you were speaking, Alice. It's very important. I know there is a lot of frustration, you know, people may feel like, well, you know, I've been talked to physicians and really try to build awareness is not working. I think it's very important to keep something in mind. One problem that our community, our disease has, we really don't have a treatment right now. There is a, you know, less incentive by the you know, by the drug makers, by the private sector, to invest resources in, you know, kind of broadening up knowledge among the medical community, which is usually something that happens even, you know, when you're getting close to have a drug to the market. Now, the good thing is this is an unprecedented time. Never we had so many kind of drug in development for this disease. I mean, it's quite incredible. I mean, I call it the renaissance of celiac disease, that we got interest by all the big players, you know, big companies that are working in this, to recognize that truly celiac is an unmet need and invest substantially in, you know, drug development in this area. So while I think there is frustration about that, I will continue, of course, to advocate as much as we can. I think I'm expecting that once we're gonna get like one or more few treatment on the market approved, we're going to have an exponential change in the ability by physician to more effectively recognize this disease. So I want to kind of give a little bit that spark of optimism, but also that highlight how important it is for us, an organization like us and others and our partners, to stay focused on how we can accelerate development of treatment for celiac disease.
Amy, you're muted. Or I can't hear you. There, try now. Can't hear you. Kate, I can tell you want to say something, but you also are muted.
No, I just wanted to tell Amy that we still couldn't hear. I mean, I feel like this whole, you know, conversation today was really important, and, you know, is a reflection of the steps that we've been taking for so long to, you know, talk about diagnosis of celiac disease, but also a reflection of how far there still is to go to getting all of those millions of people around the world who have celiac disease, but still don't know it. And especially with Iain and Nigel's work, underscoring the fact that, you know, the diagnosis is really important, even if you don't have symptoms. I think that makes our work even more urgent.
And you're one of the architects of the, or part of the write-up for the NMQF work for a poster session coming up soon, yes?
Yes, we'll be submitting that NMQF work that Amy was talking about to Digestive Disease Week, which is a conference that happens in May, as a poster. So hopefully it will get accepted there, and then we'll get to present it. Digestive Disease Week has all kinds of scientists and researchers and pharmaceutical companies who come and present their research, not just around celiac disease, but around all kinds of different gastrointestinal diseases.
And DDW, Digestive Disease Week, is one of the biggies, right? It's one of the big conferences in our field. And so hopefully, this is groundbreaking stuff. It's different than some of the other work coming up. So getting accepted there will be a huge step in getting this work on the radar screen of other researchers and physicians and folks in the field.
Yeah, because I mean, our hope is really to be able to use this data for ourselves and to be able to publish from it, but also to collaborate, you know, interdisciplinarily with other researchers around the world to have them use this data as well. We're not going to try to keep it to ourselves. We almost never keep anything like that to ourselves. We're good at talking about what we have and what we do. But I mean, that's really the goal, is to share it widely so that other people can, you know, ask questions that we might not think about that could be answered by the data.
I want to note that Maria was one of our guests on the recorded segment 3. She's here with us now, and she has a story. It's a little bit different, patient-oriented story. And I'm going to toss it to you, Maria. Do you want to share your story and any thoughts you've had about the mini conference so far?
Sure. Yeah. I'm sad that our video isn't working. Excuse me. But I hope you all do go and watch it once we have it available. Excuse me. We talked with 2 doctors about the new diagnostic methods that may be on the horizon, which was really exciting. And we talked about some of the issues with the current diagnostic methods, such as the subjectivity of pathology readings, the barriers to getting diagnosed, which kind of builds into my story, which I like to call my undiagnosis story. I won't go into the whole long spiel here. You can watch it on the other video. But about 5 years ago, I was ill. I was not feeling well. I had GI symptoms and a lot of fatigue. I went to my doctor. She thought it was my thyroid. She tested my thyroid. She said it was a little low, but qualified it as subclinical, but said it's probably just going to get worse. At that point, it was kind of like no recommendation. It was just kind of like, this is what's going to happen to you. So I was like, well, maybe there's something I can do to slow this down or make it better. So I start looking on the internet. I find some people who talk about Hashimoto's disease and they say, oh, I felt better on a gluten-free diet. So I sent my doctor a message and I said, I found this. Do you think that this could help? She said, I don't know, but there's no harm in going gluten-free. Why don't you try it? So that's how I ended up on the gluten-free diet. I felt better. I was doing well. I was many, many months gluten-free. I go to a wedding. I eat some bread at a wedding after a glass of wine and the bread looked really good. I was very, very ill after that. For 2 weeks, I had very bad GI symptoms. I lost about 10 pounds. I went back to the doctor. I had gone back on my gluten-free diet. She's like, well, we'll test you for everything. I was tested for parasites, all sorts of stuff. It was unpleasant. I couldn't eat anything for months after that. She said, well, we can't test you for celiac disease because you're being gluten-free. So that, but I didn't want to eat more gluten because I didn't want to feel worse than I already did. So I just kept eating gluten-free. I made an appointment with an endocrinologist. Getting in with a specialist in this area was difficult. It took about, I don't know, a year almost to get in. And by the time I got there, I was pregnant. And she says, I don't think you have Hashimoto's. I think you have celiac disease, but I can't test you because you're pregnant. So she did a bunch of other tests. She found my vitamin D was almost at 0 level, some other issues like that. She said, live your life like you have celiac disease and then get tested after you're done, after you've had your baby, after you're done breastfeeding, after all that. I didn't really want to go on another gluten challenge after that. So it wasn't until I started working at Beyond Celiac that I learned more about the importance of a definitive diagnosis. And they got me in touch with a celiac disease specialist in the area. And he tested me with the genetic test and found that I did not have the genes. And seeing as there's such a small percentage of people who don't have the genes who are diagnosed with biopsy confirmed celiac disease, he decided to diagnose me with non-celiac gluten sensitivity. So it took about 5 years to find out I didn't have celiac disease and to get a sort of undefinitive diagnosis. Really, to me, I feel like it's just frustrating and sort of still up in the air because really, is this the problem? You know, it's hard to know. And I know that I hear this frustration a lot from people. Like, I had this test come back positive. I had this test come back negative. I feel worse with gluten. I feel better gluten-free, but not having that definitive diagnosis and not knowing where to go next can just lead to this frustration and lower quality of just daily life. So.
Well, I want to note that, you know, if you hadn't gotten that kind of not quite definitive celiac disease diagnosis, you wouldn't have found us and you wouldn't work at Beyond Celiac now.
Yes,
so
I am happy about that.
Things happen for a reason. That's right. So
yeah.
I think that one part of the conversation. Oh wait, Amy, you lit up. Do that again. You did. You're in.
Oh, you can hear me. Oh,
thank heavens. Thank heavens.
Okay. Maybe it was something with my earphones. I don't know. I took them out, so maybe that's why. The thing that I was thinking about in terms of the mini conference in general is that at Beyond Celiac, we give very high priority to the patient voice. And I think that that is true in everything that we do. It was true when we did, going back to 2015, there was a symposium that had patients represented. When we did our summit in 2019, we had patients there. We have patients today. So you know, it's not something that we just say we care about. It's something that I think is demonstrated by not just our words, but by our actions, that we really value what the patient brings to the table and how they can influence what's important in terms of research and, you know, what's important in terms of clinical care and all of those things. So
I think excellent point. And I think that's our community as a group, we're pretty smart and very interested in this topic. And that's when we serve up the latest in research news, you know, we are constantly on the lookout for the latest interesting, relevant research. And Amy kind of turns it from science speak to English. And so if you are not a current subscriber to our research news newsletter, sign up for it. And Bailey's still standing by. Bailey, if you can put a link in the chat to sign up for our research news feed, that's great. And having an educated community helps, you know, just like Jocelyn was saying, is, you know, an educated patient, an empowered patient, and going in and saying words to your doctor like, "You're not going to test me, put that in my chart." That's, you know, that might sound a little intimidating to the doctor, but it's, we as humans in the world and patients, we're in charge of our own bodies and our own well-being. Our doctors are our partners in that, but, you know, don't take no for an answer. And I took no, you know, I took for an answer for a long time when, you know, I was symptomatic in my 20s and I like to think I didn't know better, but I just didn't argue. I just didn't fight for myself. I didn't put up with it. I mean, I did put up with it until much later, and I got a doctor who said, "Hey, no, that's weird. You should not still be anemic. You have given yourself plenty of iron. What's going on? Let's sort this out." And then I was like, "Oh, I have a doctor who's interested in what's really going on." Kate, I'm going to toss to you. I know I've already asked you stuff, but any. Go ahead.
I was going to say, I think what Gabrielle's story and what Jocelyn's story both highlighted was the need for an advocate, in that, you know, Gabrielle's mom was her advocate to say, to keep pushing for some kind of diagnosis, for some kind of answer, because she was so sick. And, you know, Jocelyn was her own advocate as well. And I think if you don't feel comfortable, you know, saying that kind of thing to your doctor, if you have a friend who's, you know, kind of pushy like that, if you have a spouse who's kind of pushy like that, like, there's no reason you can't bring other people to your doctor's appointments to, you know, advocate for you if you're not as comfortable advocating on your own behalf, or, you know, practice saying that beforehand. I mean, it's intimidating to go to a doctor. I know sometimes I have a list of like 15 questions and it turns out I only ask 5 because I'm like, well, maybe that question's kind of dumb. But I mean, you feel so much better if you go to a visit and come out of it actually having at least asked all of your questions, even if they can't answer them fully, or even if the answer is, you know, I don't know, or we'll have to figure that out. So
it's interesting when you think about diagnosis in celiac disease too. Someone had asked in the chat, is the rate of missed diagnosis, how does it compare to other diseases? So I was looking around to see if I could find that number. First of all, one of the challenges of diagnosis rates is they're really hard to pin down. And even in celiac disease, you know, we only have a range, and our range is that somewhere between 17 to 50% of people are diagnosed. So that's one, and I don't know, I don't know how common that is across other diseases. Some diseases, if you're not diagnosed, the consequences will be dire. Other diseases, the disease is more commonly known, the test is more readily offered, there aren't quite as many barriers. But the other challenge that we have in celiac disease is that there's a whole group of people who are not diagnosed because they went on the gluten-free diet without a diagnosis. And then they cannot be diagnosed unless they're willing to eat gluten again. And we've heard from our community pretty often and pretty loudly that there are a number of people who don't want to do that. So in terms of diagnosis for celiac disease, that creates an additional challenge in terms of getting the accurate number of the entire group of people who have celiac disease. And in one of the, I think this was, this came out of research by Joe Murray at the Mayo Clinic when he was looking at what he calls PWAGs, people without gluten sensitivity on a gluten-free diet. Somehow those letters line up, I'm not sure how, that when he looked at it along the lines of race, that there was a higher percentage of Black people who had gone on the gluten-free diet without diagnosis than percentage of white people. Not raw numbers, but percentages. And so, there's that challenge too, that how do you diagnose the entire community when people get frustrated with lack of diagnosis and take it into their own hands because they just want to feel better, which makes perfect sense. There's no arguing really with that, although we do always advocate for getting tested first. And that would apply even if there are a lot of barriers thrown up in front of you, as Jocelyn described. And I think her story is really illustrative of, what you have to do and how sort of you have to, gird yourself for what could be a battle to get diagnosed. Because once you kind of say to yourself, oh, I'm just going to go on the gluten-free diet, well, now the picture gets a lot more complicated, as Maria, that's part of her story too.
I see. Oh, sorry, Claire.
Go ahead.
I was going to say, I saw someone in the chat asking how long you had to eat gluten again before getting the blood test. I believe it's Dr. Hugel that speaks to that in our recording. And she was saying that, it is for, 10 days or 14 days or something like that, but that it's actually a lot less gluten than people assume, that it's less than a slice of bread. Like, Amy, do you remember she said it was like half of a slice of bread? It was much less gluten than some people assume, but it's still more gluten than some people are willing to take on for that amount of time. But that there are things coming down the pipeline slowly but surely. There's the look at the cytokines that are come out, I guess. That once someone eats gluten, almost immediately after they eat gluten, and that can be measured, and people are working on measuring that so that you would maybe only have to eat gluten one time to be diagnosed.
And there's a lot of interest in the research world in a shorter gluten challenge, if possible, as it relates to clinical trials as well, because that can be a hindrance for people participating in clinical trials. And there are a few I don't know what to call them, researchers, I'll call them, who are looking at ways to shorten that gluten challenge as best they can.
Dr. Hugel in the when you watch the recording, and again, apologies for my technical issues, that's all me, noted that the advent or the start of the antibodies doesn't line up with the damage to the small intestine, and that the antibodies will come later. The damage to the small intestine actually shows up sooner. And so if you're waiting to feel terrible based on antibodies, then there's just a mismatch there. And Alice, I think, can talk a bit about the just being persistent in talking about symptoms. There used to be, and Alice, I'll let you tell the story, but it used to be doctors would say, you can't possibly be having a celiac reaction so soon after gluten contamination. Alice, can you talk about that a little bit?
Sure. And this is, again, comes back to what everybody was talking about earlier, how important it is for your participation, right? And to hear the patient voice. I actually had been out to, when we were working way back looking for availability and affordability and access to safe gluten-free foods and the work we were doing. I was out to dinner with a group of people in a support group in Northwest Arkansas. And unfortunately, we all had celiac disease, and I won't name the restaurant, but we all got cross-contaminated. And I immediately felt like a burning in my skin, and I felt like it's kind of like tingly and crawling. And other people at the table with me said,
you think you got gluten? And I'm like, and then I'm like, oh my gosh, I'm going to get a migraine headache. We just talk about the neurologic. I'm going to get a migraine headache. And so I looked at this and said, this has to be statistically significant. We were, there was half of us at that table ended up having some kind of immediate reaction. They knew that we knew that we were glutened, whatever that term is. We coined it glutened. And that's where, started to talk to doctors about that, saying, hey, the reaction is pretty immediate. And I started actually talking to some of the top scientists about that. And what the scientists said, well, whoa, we're not thinking about this correctly. That sounds like what Maria had mentioned, a cytokine reaction. We're not thinking scientifically, the exploration, we should be looking into cytokines. So it actually, our collecting that knowledge, right, and then sharing it with the scientists, steer them into a direction of let's look at cytokines. And a lot of the research and the vaccine development has progressed in that area. And I want to thank again the community for sharing their stories, because that's how together we can advance the understanding of celiac disease and really, to improve our quality of life so we can live better longer.
There are comments coming in the chat about duration of a gluten challenge, and we do have information on our website. We're seeing somebody on our crack team of behind the scenes folks who are mostly on screen now can find a good link for the duration of the gluten challenge. And Kieran Kelly from Beth Israel Deaconess in Massachusetts, who used to be on our board of directors, helped us kind of define what the current standard is for a gluten challenge. It's actually, there's no United States established duration for a gluten challenge, which is it's a challenge. The gluten challenge duration is a challenge. It's hard to know how a physician should approach it if there's no standard for what that looks like. And there are, with the new ways of identifying gluten exposure and that sort of thing that are becoming available to us, hopefully that will get shorter and shorter. We've learned, I think the session we heard first was one of the most compelling, the one about brain damage, actual physical changes to our brain for people with celiac disease and gluten sensitivity while still on the gluten-free diet. If that damage doesn't get better, that means, earlier detection is going to be bring for us much better outcomes. And so there are a lot of people who think, well, I don't get that sick, or, I'm asymptomatic. Why would it matter? Well, you might not be symptomatic now, but if there is ongoing systemic damage, and when we used to say ongoing systemic damage, we meant to our small intestines or increased risk for lymphoma or non-Hodgkin's lymphoma or something like that. But more research coming out that it's systemic damage to our neurological system. That's, hey, mayday, mayday. We need, let's get people diagnosed so that we can intervene as quickly as possible, whether it's, right now on the gluten-free diet, or in the future, maybe an adjunct or something to take along with or to replace the gluten-free diet, someday, then that's what's important. I think, hey, thanks for the post in the chat with the link to the information about the gluten challenge. I want to note, we won't go all the way till 3:30, but I do want to note how you as a member of the community can participate. And I'm sure there are more ways, but I wanted to invite you to, again, sign up for our patient registry, Go Beyond Celiac, at go.beyondceliac.org. Share your story there. And that aggregates the information, the data that enables us to write research papers and get in front of researchers and physicians with, hey, our community says this, and we put it out there. The narrative is good too. Having actual stories from real people is very helpful. Gabrielle and Jocelyn both came to us through our Voices of Celiac project. It was their generosity of sharing their story and their name and their photo and being willing to come on this webcast that allows more people to hear more stories that are not typical. I hate to note that I'm middle-aged, but I'm a middle-aged white woman with celiac disease, and I'm kind of the poster child. That's what people think of as celiac disease, but you only see what you look for, right? So by having more people share their stories and let us put them on our website, men, parents of kids, people of color, the easier it is to educate physicians and researchers about the need for all of us to get accurately diagnosed and be part of the tapestry, of the picture, the collage of people who have celiac disease.
I have a quick update from Jocelyn. This is like one of those truth is stranger than fiction things. Yeah, she had a massive power outage on her street and everyone lost their electricity. And so she lost her Wi-Fi connection. So
well, that's why she didn't leave mad. She's like, that's it, I'm out. You guys, no, she didn't do that. I didn't think she did, but just, whew. Consider participating in a clinical trial. You'll, if you're on our email list, you'll see that we're actively partnering with a number of companies who are recruiting for clinical trials, and super helpful to be able to help drive research that way. If not enough people sign up for clinical trials, the research just takes longer. And we've heard from people who said, "Hey, I filled out the survey and I didn't hear, or they turned me down, or whatever." It's not you. It's not you. They're looking for things that are very specific. They'll say, "Are you still symptomatic on the gluten-free diet? Have you been gluten-free? Do you still have symptoms?" They're looking for specific symptoms based on the way they've written their research studies. So keep trying, keep raising your hand, and hopefully together we can fill the ranks if you're willing to do that. And there are opportunities to participate in clinical trials that don't require you to take a drug. So just keep an eye out there, and we'll make progress faster. And then finally, we've talked a lot about research initiatives that Beyond Celiac is leading the way on. Our diversity study, our diversity work with the National Minority Quality Forum was session 2. We're providing an established investigator grant to the researchers from Sheffield that we heard from in our first session. And Beyond Celiac, we're a nonprofit, and we raise money from the community. We raise money from private foundations. We get some money from corporate support, but we really ask you, our community members, to support us. And so if you go to beyondceliac.org/donate, you can fund research, directly fund research, and help us get to the goal. I'm going to wrap us up shortly. Any last parting words? Any last thoughts that anybody wants to share before we bid you adieu? Alice's face says no. Kate and Amy, nope. You all have been a wonderful audience. Again, apologies for the last session not coming through, but we'll get it posted right away. And we will send you a reminder and a link. We'll also send out a survey afterwards, so you can give us feedback on the mini conference and give us feedback on topics you might want to see for future presentations. Again, happy Thursday, happy mini conference. Enjoy the rest of your day.
So long, everyone.
Thanks, everybody. Goodbye, everybody. And for those who've supported us, thank you so much for your support. You now can see some of the fruits of that support. So thank you for your time and also your funding.